I believe we've been in constant touch with each other through mail and WhatsApp, so let's just get on with it. First of all, I'll briefly introduce our esteemed judges. First is Dr. Sindhu. Dr. Sindhu Shivanandan, whom I admire profusely, is Professor of Neonatology at JIPMER, Puducherry. I would need all of the next 1 hour, I believe, to do some justification to her introduction, really. So she's one of the most systematic academicians in the country. She's a DM from AIMS, New Delhi, and that is after she completed her fellowship in University of Calgary at Canada. With several accolades to her name, she's one of the key individuals involved in formulation of the country's neonatal medicine guidelines. Welcome, Sindhu. Next up, we have Dr. Anish. Anish is another one of my very close friends. He's consultant at Surya Hospital, Mumbai. He's another gem that this field has come to know. He's completed a super specialty DNB training in KIMS itself, and then went on to do a double fellowship in neonatal perinatal medicine and neonatal nutrition at University of British Columbia, Vancouver. You could search all the high impact journals and you will find at least one of his publications there. Welcome, Anish, and very good to have you here.
Thank you.
We have Dr. Tejo Pratap, yet another friend. He's consultant and head of department at Fernandez Hospital, Hyderabad, which the institute itself is a very esteemed one. He did his DM from AIMS Delhi, and he has more than 50 publications in index journals. If he's your examiner, then you would need to be very, very attentive and sharp. He's very well read and has been at the forefront in research methodology, academic as well as clinical spheres. Welcome, Tejo.
Thank you. Thank you.
And Dr. Bharati Balachandar, whom I know since she was probably 17 years old, is my JIPMER junior and is currently assistant professor of neonatology at St. John's Medical College, Bangalore. Right from her PG days, she has been meticulously involved in research, and she's one of those with a Midas touch, I would say. I wonder whether her cabinets are now overflowing with her gold medals. Welcome, Bharti. We also have here Dr. Rajendra Prasad. He's assistant professor at AIMS, Hyderabad. He did his post-graduation and DM from PGIM at Chandigarh. He's a dynamic researcher, and he's with very keen interest in conducting meta-analysis and systematic reviews, yet such a down-to-earth person and an enthusiast of perfectionism. You would realize that he knows in and out of any subject in the field within a few minutes of striking a conversation with him. Welcome, Dr. Rajendra Prasad.
Thank you, ma'am.
We have one more judge who's yet to join us because probably she's stuck with COVID duty. Dr. Swati Upadhyay is Assistant Professor of Neonatology at Atal Bihari Vajpayee Institute of Medical Sciences and Ram Manohar Lohia Hospital, New Delhi. She's one of our students. She completed the DNB Neonatology at KIMS. And anybody who's met her and all my senior colleagues will easily agree with me if I state that she's exceptional at whatever she does. Clinical, teaching, research, presentations, and even non-medical talents, several of them. So we'll welcome her later, Dr. Swati, for you. So with that, we'll start with the award category presentations. Two judges have blinded marking, completed their blinded marking in this category, and two other judges who have not gone through the manuscripts are here to judge the presentation style and effectiveness of that presentation independently. So all four of them don't know what the other people are marked. So you'll get total unbiased judgment. So with that, I'll first invite Dr. Arif. He's from KIMS Trivandrum.
Yes, ma'am. Sir, can you see my slides? Can I begin, ma'am?
Yes, it's visible.
This paper is about respiratory insufficiency patterns in extreme preterm infants, which is an intense scenario, from an intense scenario. Every baby's birth gives a coolness to our eyes and as well as precious to parents. But being a parent of extremely low gestational neonate is a very difficult situation. And because of the maelstroms or the adverse and oscillating course the baby is facing in the NICU, most of this adverse course is shared by the respiratory insufficiency. Baby will be on different types of modes of ventilation, different FiO2 settings, and this shares the maximum time of baby's NICU course. Then only baby will be going to discharge, and that will lead to the discharge outcomes and all. So from that thought, we wish to find is there any predictable patterns or course of respiratory insufficiency in extreme preterm babies? In this thought, we reviewed the literature. We could hardly find very few literature which describes the predictable patterns of respiratory insufficiency in extremely low gestational age babies, that is from the periviable gestation to 28 weeks of life. After this our study, what we came to conclusion that we could identify extremely preterm babies are at lower risk of bronchopulmonary dysplasia by seeing the third day as well as second week respiratory pattern of the babies. We can somehow prognosticate, counsel, and we can allocate resources and decision making from this study. What are the implications of long-term respiratory insufficiency in a neonatal ICU? Obviously, baby will be getting long-term NICU stay. That itself will lead to the risk of infection, risk of being evaluated for sepsis and other factors, and financial concerns for the family, and the role of empirical treatment in between, and finally bronchopulmonary dysplasia. And at the last, the family stress will be there, and finally the long-term morbidities. These are the implications of respiratory insufficiency baby will be going through in the NICU stay. These are the reasons why we conducted this retrospective descriptive study. Our center is a level 3B NNFI accredited hospital, KIMS neonatology unit, and we studied over the period of 2017 to 2019 extremely low gestational age neonate. 46 eligible babies were there. Even though the number is very small, this is from a single center study. We found that we should report the patterns we observed in our study. The basic things were the birth weight, that is median intercostal range, was around 849 gram, and gestational age was 26 weeks. And among the 46 babies, around 60% comprised less than 750 grams. And the antenatal steroid coverage was just above 50%, because most of these babies were the delivery were emergency delivery because of maternal issues, and the coverage was not complete. And the chorea amniotic percentage was only 15.2%. And how did we classify it? For this classification, we borrowed a studies that have conducted early. In that studies, what they have did was they looked into the FiO2 requirement on day 3 as well as on day 14. In this in this slide, we can see that even though the babies are getting less than 30% FiO2 on the first third day, by 14 day, the first group is getting continue to get less than 30% of FiO2, and the second group is getting more than 30% of FiO2, and the third group, it is the baby starting with more than 30% FiO2 and continue to getting more than 30% FiO2 on day 14. And the final group, the baby started with more than 30% FiO2, but at the end of 14 by 14th day, baby is on less than 30% FiO2 irrespective of mode of ventilation. And we classified that 4 groups in different categories. Category 1 is persistently low group, category 2 is progressively worsening, and category 3 is persistently high group, and category 4 is progressively improving group. What we found was almost 82% of our 46 babies comprised in the category 1, that is persistently low group. Among them, the BPD incidence was around 32%. And that means a positive note of that is 78% of that group has got no requirement of oxygen by 36 weeks of life. And we can conclude the rest of this thing. Category 1, BPD rate were around 31.5%, and category 2 to 4, that is even though some babies were started with less than 30% FiO2 on day 3, or babies started with more than 30% on day 3, compiling both day 3 and day 4, they will be getting a BPD rate of 62%. Gist of our observation in this retrospective analysis was The BPD incidence was 36.7%, which is almost equal to the reported incidence of BPD across this extremely low gestational age neonates. Some studies have reported more than up to 60% of incidence of BPD among this 23 weeks to 28 weeks of gestation. And the most important thing is our category 1 babies, that is the requirement of FiO2 by third day as well as on day 14. It is comes around 82.6%, and their incidence of BPD is 32%, around 31.5%. And take home points from this study is low FiO2 on day 3 and the baby is getting less FiO2 on day 14. We can conclude that there is a less incidence of bronchopulmonary dysplasia. And if the baby is getting high FiO2 on day 14, there is a higher chance of BPD. What we can add to what we can tell, like we have conducted another analysis of this study. Among all these three groups, our the sepsis workup and the investigation, everything was similar. So we can prognosticate or we can resource allocation, everything we can curtail while if we are following these type, if the babies are low effort on day 3, we can somehow we can tell that there is a less
One
incidence
more
of
minute left.
okay, and this will help in decision making and prognostication. But the one most of practical benefit is this is our study published last year, which analyzes the hospital care to family in extreme preterm infants. It comes around 7,500 Indian rupees. By these studies, we can optimize our care priorities and decrease this cost further. Thank you, sir.
If you can stop sharing your screen.
Okay, ma'am.
I'll ask the judges to take over from here.
1 minute, ma'am.
Thank you, Arif, for the nice presentation and a very interesting study.
Yes, Sindhu.
Thank you, ma'am.
My question to you is on the definition of LGAM that you had used for your study. Did you include 28 weekers or was your population less than 28 weeks?
Included 28 weekers, ma'am. 28 weekers and below, ma'am.
Okay. Thank you.
Thank you, ma'am.
A good presentation, Arif. My question was, you mentioned that this study will help in cost reduction. Can you clarify on that, please?
Sir, sure, sir. Sir, while analyzing the this investigations and this resource allocation for that our empirical treatment, almost all these categories will be having the significantly same amount of investigations, X-rays, and sepsis workup and all. If we are predictable, we can predict that if the babies if the baby had a less FiO2 on day 3 as well as on day 14, and in the intermittent hypoxia happening beyond that age, we can see if the baby is clinically stable. We don't have to further evaluate, or we do not have to invest in more investigations, sir. So, and we can help the parents that the baby is going to be fine. In that way, we can reduce the cost, sir.
Less investigations will be done.
Yes, sir.
Thank you.
Should I film that? Okay. Arif,
sir,
you have presented really well.
Thank you, sir.
So two things that predict is that when you are including your subjects, did you look at any other baseline factors? Because suppose the mother had any chronic PROM before your enrollment, because of the severe oligohydramnias and other things, the lung may not be a similar way compared to other babies. Of course, your numbers are very smaller, so it will be difficult for you to do it. Did you look at any baseline factors which either at the time of enrollment or you have removed those babies like
No,
malformations?
sir. Actually, our total sample size was around 60, sir. We have eligible candidates were 46. In that 46, the chorioamnionitis, clinical chorioamnionitis was around 15.2%, sir. And the antenatal steroid coverage were around 50%, sir.
Okay. I am not interested in chorioamnionitis. That is also one of the risk factors. But even a chronic PROM, especially these periviable gestation babies, they can have a little impact on the lung growth.
Okay, sir.
And second one is that BPD definition I wanted to know. Did you look at the moderate to severe BPD as per the previous NICHD
No, sir.
classification?
No, sir.
Or
We
in,
what we searched, what we looked into was if the babies get on oxygen at 36 weeks of life, sir. That only we have not separately moderate or severe BPD, not classified, sir.
no, previous NSHD classification, even if the baby doesn't require 36 weeks of gestation, but if it requires a 28 days of
Okay, sir.
life, if you have oxygen, still that will classify as mild BPD.
Okay,
Okay.
sir. Okay, sir.
Did we look at all the babies who are required 28 days of oxygen?
Yes,
Or
sir.
only those who are requiring at 36 weeks of gestation some amount of oxygen or respiratory support, you have looked at it?
Sir, in the complete paper, we have looked into that part also, sir. Respiratory support at 4 weeks of life also, we have this thing, sir, included, sir.
Okay. Thank you.
Thank you, sir.
Dr. Arif, that was a wonderful presentation. I
Mm.
just have two questions to you. One is, why did you choose a cutoff of only less than 30 and more than 30? Can we have more categories and then decide? And the second is, why did you choose day 3 and day 14?
Ma'am, actually, our study was less than 28 weeks gestation, ma'am. So we came to conclusion that that group of babies will have a different physiology and the prematurity is almost similar, but obviously the periviable babies will be little more sicker than the 28 weeker babies. And the day 3 and day 14, madam, while we are reviewing the literature, it was hardly very few studies only describing the patterns, ma'am. In that studies, they have used a 0.23, that is 23% and 25%. But it is very difficult in a bedside distinction of severity. So we take as 30% less or more than. That is day 3 and day 14, ma'am.
Thank you.
Thank you, ma'am.
Shall we move to the next paper, judges?
Yes, yes.
Yes, ma'am.
Thank you. Thank you.
Yeah. May I invite Dr. Deepak? We'll be sharing the screen from here, Deepak. That's what you wanted, correct?
Yes, ma'am.
Yeah. You'll have to indicate when we need to change your slides probably.
Yes, ma'am.
Is this okay?
Yes, ma'am.
Yeah, start please.
So good afternoon, everybody. I am Dr. Deepak Sharma from Shalini Hospital, Hyderabad. I will be speaking on a quality improvement initiative to decrease number of pricks in VLBW neonates during first 2 weeks of life. Next slide, please. As you all know, VLBW neonates in the NICU undergo a multitude of painful and stressful procedures. Repeated exposure to pain leads to long-term neurodevelopmental, emotional, and social functional abnormalities. Next, please. So we observed that neonates were undergoing too frequent painful procedures at our center. So we aim to decrease avoidable painful pricks by making fixed and standard protocols in the unit. Next, please. This was a quality improvement initiative conducted over a period of 6 months from July 2020 to December 2020. Next, please. So all VLBW units admitted to NICU were included in the study. Next, please. So the study period was divided in 3 phases: baseline phase, intervention phase, and sustenance phase. Next, please. So during baseline phase, we collected data on number of pricks suffered by VLBW units in the first 2 weeks of life and data on purpose of prick at each instant. Next, please. So to understand what all factors can contribute to increase in neonatal pricks, we made fishbone diagram. Based on all these factors, data was collected during baseline period. Next, please. A total of 6 neonates were enrolled with mean gestation of 30 weeks and mean birth weight of approximately 1.3 kg during baseline period. Mean number of pricks received by each VLBW neonate during this period was 55, ranging from 49 to 71. Next, please. I am projecting baseline data by Pareto diagram. You can see that nearly 70% of the pricks received were for GRBS monitoring only, closely followed by pricks for securing line, clustered sampling, sepsis screen, and blood gas analysis. Next, please. Next, please. Next.
Dr. Deepak, we've lost your audio, I believe. Deepak, we've just put your presentation on hold and we stopped the timer also. We hope to have you back soon. Sindhu, Anish, are you able to hear him? Is it something at our end?
No.
No.
It's video and audio are paused.
Video we have paused.
Okay.
Let me move. Give you one more data.
Judges, he's gone off from the panelist list. He's probably lost his connection.
Just
Shall we move to the third one and come back to him?
Yes, it is.
Yes, okay. Dr. Minu, are you there? Panelist.
yes.
It was under Dr. Minu, we're waiting for you. Yeah, are you there? Correct. Then you can please share your screen then. Good. Start.
Start, ma'am.
Yes, Dr. Minu.
Good afternoon, all. Myself, Dr. Minu, a DNB resident. I would like to present my paper under the title, The Effect of Intact Umbilical Cord Milking versus Delayed Cord Clamping on Hematological Parameters in Late Preterm and Term Neonates at 72 hours of life. The study was conducted in the Department of Pediatrics and Neonatology at Anandapuri Hospital under the guidance of Dr. Kamala, Dr. Mili, and Dr. Gobika. Coming to the introduction, according to the latest National Family Health Survey, highest prevalence of iron deficiency anemia is found in children below 5 years of age. So iron store at birth is a major factor which influences the growth and occurrence of iron deficiency anemia during infancy. So these stores are determined by the transplacental iron transfer to the fetus. So two interventions which transfer blood from umbilical cord towards the baby is, one is delayed cord clamping and another is umbilical cord milking. So these interventions provide term neonates with 40 to 50 mg per kg of extra iron, the effect of which can prevent iron deficiency anemia during the age of 1 year. So in our hospital, what we practiced was delayed cord clamping. Since we have to wait 60 seconds for the intervention, some babies who need immediate resuscitation are not able to achieve this beneficial intervention. So milking provides a placental transfusion without postponing resuscitation and can be completed as quickly as immediate cord clamping. So this study was conducted to compare milking and delayed cord clamping in newborns more than 34 weeks of gestation. So our objective were to compare the hemoglobin level and serum ferritin level at 72 hours of life in two groups. Also the incidence of hyperbilirubinemia requiring phototherapy by measuring the serum bilirubin level, and also we compared the duration of phototherapy in two groups. Ours were a randomized trial and conducted during the study period from June 2020 to March 2021. During the study period, all newborns more than 34 weeks of gestation were included in our study, and the babies who were born with severe birth asphyxia, CNS congenital or chromosomal anomalies, and babies born to COVID positive mothers were excluded from the study. Coming to the methodology, all the obstetricians were taught the proper method of intact umbilical cord milking for the university of the process, since we were practicing DCC in our hospital. A random sequence was created by random number generator, and clamping technique was assigned to each baby at the time of delivery. During delivery, the obstetricians carried out either IUCM or DCC according to the assignment. How we did the milking in the cord milking group was that the baby will be held at or below the level of placenta. Then about 20 centimeter length of the cord was held and milked towards the baby at approximately 10 centimeter per second. And the cord was then released and allowed to refill with blood for a brief 1 to 2 seconds. And the process was repeated 3 times before clamping. And we could finish this procedure within 20 seconds. In the other group, that is delayed cord clamping group, the cord was clamped after 60 seconds from the time of delivery. And for the investigation, we took 4 ml of venous blood sample for bilirubin, hemoglobin, and ferritin measurement at 72 hours of life. So statistical analysis was performed using SPSS software 20. Categorical variables were expressed as frequency or percentage, and quantitative variables were expressed as mean plus or minus standard deviation. And to compare the hematological parameters between 2 groups, independent t-test was used, and a p-value of less than 0.05 was considered threshold for significance. Coming to the result, during the study period, there were 140 newborns and 20 were excluded according to the exclusion criteria, and the remaining 120 were categorized into 2 groups. There were 57 in the intact milking group and 63 in the delayed cord clamping group, and both were analyzed for the outcome. This table shows the baseline characteristic of 2 groups. All the baseline characters between 2 groups, that is IUCM group and DCC group, all the parameters were comparable with a p-value of more than 0.05. And this was the result what we got. The hemoglobin level and the ferritin level between 2 groups were comparable with a p-value of 0.53 and 0.8 respectively. And the incidence of hyperbilirubinemia requiring phototherapy was also comparable, which was almost 50% in IUCM group and 49% in DCC group. Also, there was no difference in the babies requiring phototherapy in late preterm and term group. And the duration of phototherapy required was also comparable with a p-value of 0.7. This was a box and whisker plot which is plotted for the comparison of serum ferritin between 2 groups. For both groups, the median value were comparable with a comparable interquartile range. So coming to the discussion, there have been many trials demonstrating the benefit of DCC on the hematological status in term babies, but there are limited trials looking at the benefits of UCM in general and especially in term neonates. So these are the various studies which we compared. After the starting of our study, new study was published by AIMS in 2020 December, that is study by Mangala et al., which considered group babies born more than 35 weeks, and they compared IUCM and DCC only. And for the ferritin, incidence of hyperbilirubinemia were comparable. And in the hematocrit, they have found a significant difference of less than 0.002 in IUCM group, but the complication, there were no complication due to this difference. And in a study conducted by Jaiswal et al., the hemoglobin, ferritin, and incidence of hyperbilirubinemia was similar to the results what we got in our study. And in a study conducted in Kerala by VC Manoj et al., they took study group as preterms, that is between 28 to 32 groups. In their study also, the hematocrit was comparable, but they got a complication as IVH higher in early cord clamping group, since they compared early cord clamping with umbilical cord milking. So the studies which compared our study, the similar studies, we got a similar results in the hemoglobin, ferritin, and incidence of hyperbilirubinemia group. So regarding the method of practicing IUCM or DCC, all obstetricians in the institution were comfortable in doing either of the above methods, and they gave the feedback that it's easy for them to do IUCM rather than DCC as less time is consumed for UCM. So all the AP has recommended DCC for all newborns. It may not be feasible in all deliveries. So our study highlights the importance of practicing intact cord milking in scenarios where DCC cannot be practiced. Even IUCM can be done in well babies at birth instead of DCC, as IUCM did not show any complication and was easy for gynecologists to practice. So to conclude, all the hematological parameters which we compared and the incidence and duration of phototherapy required was also comparable, and none of the babies had complications like prolonged hospital stay, polycythemia, hyperbilirubinemia requiring adjuvant therapy. Hence, IUCM can be recommended for all newborns more than 34 weeks gestational age in which DCC is not feasible or not practiced for any reason. The limitation of our study was, since the sample size was less, more large sample size randomized controlled trials are needed, preferably multicentric studies recommended to confirm this. Thank you.
Perfect timing, Dr. Meeno.
Thank you, Dr. Meeno. A very energetic presentation. So I would like to ask you, you said that your sample size was less and you have recommended a very large sample size study. Can you explain to us how you calculated sample size for this study?
Actually, this was an interim study, madam. We calculated sample size according to the study conducted by Dr. Jaiswal et al. And we got a minimum sample size of 105 in each group. We are planning to continue the study.
Which was your primary outcome, which enabled you to calculate the sample size?
Hematological parameters at 72 hours of life, ma'am.
But you have two hematological parameters there, right? Ferritin as well as hemoglobin or hematocrit. Which one did you use to calculate sample size?
Used hemoglobin, madam.
Okay, thank you.
Good presentation, Dr. Meenu. Did you plan this as a non-inferiority trial or a superiority trial, and what is the difference between the two? And one more question is that you said you excluded severe birth asphyxia, right? How was that distinction made right at birth? Because this decision has to be made immediately after the baby is born. So how were those babies excluded?
Actually, before the delivery itself, we will take which group we have to do which method. But when it is like when there is severe asphyxia, we don't do either milking or delay. We just do the immediate cord clamping and take the baby.
So what was severe asphyxia? Not crying at birth, or was
born limp or?
Okay. Okay, thank you.
Dr. Meeno, because it is a randomized trial, most of the confounding factors will be addressed. What do you feel that in your study, to take it to external other hospitals, what could be your confounding factors in your study? Because I couldn't see a lot of tables in your slides, but I just wanted to know what are the confounding factors that you are able to see and how did you correct it?
Factors, this hyperbilirubinemia can be due to any blood group incompatibility. That may be a confounding factor.
Okay, but your primary outcome is hemoglobin and ferritin level.
Then maternal hemoglobin level can be.
Okay. Did you look at it? Did you look at the mean hemoglobin values between the two groups?
Yes, yes, sir. Was
okay. How were they? Comparable.
It was comparable, sir. There was no much
difference. Did you look at the cord hemoglobin levels also? Did you look at
we didn't check, sir. No, sir.
Okay, thank you.
Meenu, that was an excellent presentation and very energetic too. So I just have one question. You have not mentioned anything about returned informed consent. When was consent taken in your study and when was the randomization done? And if a baby did have severe birth asphyxia, what did you do? Did you discard the randomization?
Actually, we before the study was started, we took through the online random generated table. We have made a randomization table, and so before each delivery, we will tell the obstetricians to do either of the method. If that baby is born with severe birth asphyxia, we will exclude that baby from the group. Like.
Okay. And when did you take consent from the parents?
Consent we usually get when the mother gets admitted only.
That's it, no, Bharti? Shall we move on to the next
Yes.
presenter? Yeah. Dr. Deepak?
Yes, ma'am.
Yeah.
Yes.
Shall we start screen
Yes.
sharing?
Yes, ma'am.
Yeah.
So good afternoon, everybody. I'm Dr. Deepak Sharma from Shalini Hospital, Hyderabad. I will be speaking on a quality improvement initiative to decrease number of pricks in VLBW units during first 2 weeks of life. Next slide, please. So as you all know, VLBW neonates in NICU undergo a multitude of painful and stressful procedures.
We can move to the slides which he stopped, no, I think.
Pareto chart.
Yeah.
Pareto chart.
Yeah.
Next. Yeah. So I am this is the Pareto diagram. I am projecting baseline data by Pareto diagram. Nearly 70% of the pricks were for GRBS monitoring. Next, please. So nearly 10% of the pricks were for securing IV line. Another 10% of pricks were for clustered sampling. 5% pricks for each for sepsis screen and blood gas analysis. Next, please. So after analysis of baseline data, we had to plan interventions to cut down on number of pricks. For that, we formulated our QI team, aim statement was finalized, and test changes are planned. Next, please. Our QI team included a neonatal resident who was the team leader, neonatal consultants, NICU residents, and NICU nursing staff. Next, please. The aim of our QI was to reduce pricks in VLBW neonates during first 14 days of life by 30% of the existing rate over a period of 3 months. Next, please. So to achieve our aim, key driver diagram was made. Primary and secondary drivers were identified based on which test changes were identified. Next, please. So as seen in our Pareto chart, the most common cause of GRBS neonatal pricking was for GRBS monitoring. So during first PDSA, our plan was to reduce GRBS monitoring. For that, we did root cause analysis of the problem, that why babies are receiving so many pricks for GRBS monitoring. This we did using 5 whys methodology of root cause analysis. A root cause analysis, we found that it was lack of GRBS monitoring protocol which was responsible for so many pricks. So we made a protocol of GRBS monitoring for VLBW neonates. After implementation of that protocol, we found that the number of pricks reduced. So we asked residents to follow the newly developed protocol. Next, please. So this was the GRBS monitoring protocol for VLBW and ELBW units, which we made for our center. Next, please. So after GRBS monitoring, the second most common cause of pricks was for securing IV lines. So during PDSA2, our plan was to decrease number of pricks for IV cannulation. Again, for that, we did root cause analysis, that why so many pricks for securing IV lines. This we did using 5 whys method of root cause analysis. Next, please. So we found that the frequent pricks for IV cannulation was because of 2 reasons. First, prolonged TPN or IV fluid need, and secondly for IV antibiotics. Now, why babies were on prolonged IV fluids or TPN? It was because of conservative feeding policy. Why conservative feeding policy? Because people are worried about risk of NEC. And why risk of NEC? Because of non-availability of mother's own milk. Similarly, why prolonged IV antibiotics? Because people were not adhering to unit antibiotic policy. Now, why they were not adhering to unit antibiotic policy? It was because of fear of infection, since babies were on prolonged TPN or IV fluid. And once babies are on central line, people are worried about infection. Again, why prolonged IV fluids? Because of conservative feeding policy. So to overcome the problem of conservative feeding and non-availability of mother's own milk, we conducted educational session. Next, please. During these educational sessions, we focused on importance of aggressive enteral nutrition, importance of mother's own milk, methods to improve mother's own milk, and antibiotic stewardship. Next, please. So most important was improving mother's own milk, which can take care of conservative feeding policy and decrease antibiotic use. Now, the main hurdle was how to improve mother's own milk. For that, we did a literature search. We found a very good quality improvement initiative study done at another unit in Hyderabad with Dattatreya et al. In that, all those interventions which led to significant improvement and were cost effective, didn't require much of resources, and were feasible at our center, we incorporated those interventions in our protocol. Next, please. So this was the feeding protocol for VLBW units and protocol ensuring mother's own milk, which was implemented at our center. Next, please. So first most number of pricks for GRBS we took care in first PDSA cycle, second for securing lines in second PDSA. Next for most common cause of pricks was for clustered sampling.
Deepak, one more minute left.
Okay, sir. That was not a concern for us. So we we took care of sepsis screen and ABG. Next, please. So during this cycle, we had discussions among team members, reviewed available evidence on the utility of investigations, and we finalized the protocol and CBP-CRP ABG. Next, please. So this was the finalized protocol for sepsis screen and ABG. Next, please. So to understand the impact of our QI, process, outcome, and balancing measures were identified. Next, please. These were the process measures. Next, please. Next, please. And outcome measure, total number of neonatal pricks for each VLBW unit during first 14 days of life. Next, please. So these are the balancing measures identified. Next, please. So coming to result, there was no difference in the baseline characteristic among the neonates enrolled during the 3 phases. Next, please. So next, please. This is the statistical process control chart showing significant decrease in the number of pricks received by each VLBW neonate over a period of time. Next, please. So concluding, multi-interventional quality improvement strategies targeting institutional protocols on the procedures to be performed can decrease the avoidable neonatal procedures. Next, please. Thank you all.
Thank you, Deepak, for initiating this quality improvement study. My question to you is, you had the skin pricks as both as a process outcome and an outcome measure. How
Yes.
do you differentiate these? What is a process measure and what is an outcome measure?
Ma'am, actually, our process outcome measure was number of pricks, total number of pricks, and process measure was number of pricks for each investigation, like for how many pricks for GRBS, how many pricks for sepsis screen. Outcome measure was total number of pricks.
So, as a clinical outcome, what is more important for a clinician? Is it the number of prick, or how do you choose your outcome measure?
Now, outcome measure, actually our aim was to decrease pain. So pain can be decreased by total number of pricks. So that's why our outcome measure was total number of pricks.
Okay. Okay, thank you.
Thank you, ma'am.
Deepak, that was very good. It's always good to hear a QI project being conducted very nicely. Can you elaborate 2 limitations of your study, like this whole QI process?
Yes, sir. The main 2 things, 2 limitations were, first, it is a single-centered study with very few, almost a total 36 number of neonates enrolled in that. And the interventions which we did may not be applicable to other centers, because for our center, the number of pricks may be there for different reasons, and other center, it may be for a different reason. Secondly, coming to the balancing measures which we took, the number was very less. So we don't know whether with this intervention, any adverse outcome was there or not.
Okay, and did you look at the level of training of the person who's doing a prick? Like a junior resident will need more pricks than a senior fellow for the same test. Was that looked at?
No, sir. Actually, all those procedures were done only by nurses, and we didn't differentiate whether it is done by senior nurse or junior nurse. We took as total number of pricks for investigations. Like one time we are doing GRBS, another prick we are giving for like sepsis screen. So we took total number of pricks.
So for a sepsis screen, if the nurse had to do 3 pricks, also it was counted as 1.
No, sir. It was actually it was taken as 3 pricks.
Okay. All right. Thank you.
Thank you, sir.
Deepak, after your all PDSA cycles, what are the things that you wanted to tell to all the other units, which are most important things to be done to decrease the number of pricks?
Sir, first thing what I noticed is most of the centers don't concentrate on number of pricks for GRBS monitoring. We never look into the number of pricks received by babies for GRBS monitoring. And all babies who are on, especially on IV fluids or TPN, they repeatedly undergo pricks till the time they are on IV fluids. But what happens is once initial sugars are stabilized, most of the times they don't go into hypoglycemia or hyperglycemia. after initial stabilization, one or maybe daily once sugar monitoring will be sufficient. But at most of centers, it is 3 or 4 times a day. So if we cut down on number of pricks for GRBS, that will be a very good thing. Second thing, we didn't found any protocol anywhere from the Premier Institute also who targeted a number of pricks for VLBW neonates. GRBS monitoring protocols for late preterm and term neonates are there, but we didn't get anywhere any protocol like this for preterm babies. So everyone was doing whatever they were thinking is appropriate. So protocolization of that is very important. What we try to do for this study.
Second thing I wanted to ask you is that, did you look, suppose first thing you said is that GRBS protocol you have rationalized.
Yes, sir.
After that you have done some other PDSA cycles.
Yes, sir.
Between the 2 PDSA cycles, when you are doing it,
yes,
does the number of pricks were statistically significantly reduced? Which factors reduce the statistically significant reduction of pricks?
Sir, actually we didn't, we were monitoring this by only using this statistical process, means run charts. In run charts, the number was not significant to say ki after 1 PDSA cycle that it was statistical significant. For that means we have to see for shift and shift, but there was no shifting. But overall, after total QI, means comparing from baseline period to the QI period, the number was significantly reduced statistically. But after each PDSA cycle, we didn't see it. We just monitor it using run chart.
Okay, thank you. Bharti.
Thank you, sir.
Deepak, that was a wonderful QI study. My question to you is that there was a significant, I mean, there looked like there was a significant drop between cycle 2 and cycle 3, if at all, I mean, if I remember from your slide. So we just want to know what was that made the difference between cycle 2 and cycle 3, which showed the drop. And my second question is, are you sustaining all your interventions?
Okay. So ma'am, regarding first question, actually it was from baseline to first PDSA cycle where there was a significant drop. So there was a significant drop because as seen in Pareto chart, most of the pricks were for GRBS monitoring and our first protocol was for GRBS monitoring. So there was a significant drop on number of pricks during first cycle itself. There was not much of a difference between first and second cycle, but still the number of pricks were reduced after incorporation of second cycle. Your second question, ma'am?
Are you able to sustain your intervention?
Yeah, ma'am. Actually, it was a thesis project for one of my colleagues. So that after completion of that thesis product, we didn't look into that. That was one of the limitation of our study. This sustenance period was looked only for 2 months. After that, we didn't look. But definitely looking at the scenario, the number of pricks have significantly reduced.
Okay. Thank you, Dr. Deepak.
Okay. Thank you, ma'am.
Thank you all. Now we move on to the next session. That's the oral paper presentation. I would like to invite our judges, Tejo sir, Rajendra Prasad, Sindhu ma'am, and Anish. So we'll start with the first candidate. Vineet, are you there? Yes. Vineet?
Yes, I am here. Yes, I am here.
Okay. So 6 minutes is the time. At 5 minutes, we will give you a warning, and rules are same. And numbers already we have given to you. As per the order, we will call you. So Vineet, you can share your screen. Okay.
Yes.
Vineet, any technical difficulties? Vineet?
Yes, yes. Sir, I'm just sharing, sir.
Okay, okay, okay.
My screen sharing is paused actually. Hello, sir.
Hello. Huh?
My screen sharing is shown as paused.
stop and again start once more. You can try.
Okay.
Meanwhile, can we? Vineet?
Yeah, sir.
Just you try it. We'll move on to the next panelist, and we'll just have Anupama S. Pillai on screen.
Okay.
Anupama?
Yes, sir.
Yeah, please start sharing your screen.
Shall I start, sir?
Yeah, sure.
Good afternoon, all. I am Dr. Anupama S. Pillai, DM Resident at SAT Hospital, Government Medical College, Trivandrum. The title of my study is Comparison of Transcutaneous Bilirubinometer Reading at 3 different sites in evaluating neonatal jaundice in newborns more than 32 weeks gestation in a tertiary care center. Coming to the background, the gold standard for estimation of hyperbilirubinemia is by measuring serum bilirubin levels. The search for a non-invasive and reliable technique led to the introduction of transcutaneous bilirubinometer, which works on the principle of spectrophotometry, in which it measures the optical signals from the tissue bilirubin and converts it into electrical signal, which is displayed on the LCD screen. It measures the tissue bilirubin and hence is a better predictor of cardiac arrest. But the limitation is that it is less useful once phototherapy is started, as the skin gets blanched. Different sites were used for measuring transcutaneous bilirubinometer values. It has to be done over bony prominences where the skin is thin. Literature shows that both forehead or sternum can be used as sites. The forehead values were said to underestimate serum bilirubin levels. This study was intended to find the site for this TCB having maximum correlation with the serum bilirubin levels. The objectives of my study was to determine the correlation between transcutaneous bilirubinometer readings done at the forehead, sternum, and pubic symphysis with serum bilirubin levels in estimation of jaundice in newborns more than 32 weeks gestation cared at the newborn nursery in Government Medical College, Alappuzha. The secondary objective was to determine the correlation of transcutaneous values with lower and higher serum bilirubin levels, that is less than 15 and more than 50. My study design is a prospective observation study. The study setting was NICU at Government Medical College, Alappuzha, with a study duration of 1 year and sample size of 160, assuming an incidence of jaundice of 60% in term babies. We included newborns more than 32 weeks gestation from birth to 120 postnatal hours with clinical jaundice at least up to thighs. And also we excluded preterms who were less than 32 weeks, babies born through meconium stain amniotic fluid because of the risk of skin pigmentation, and also babies who received phototherapy. Infants with jaundice from zone 3 of Kramer index was selected. Physical examination was done in ambient daylight only. We did TCB with Drager transcutaneous bilirubinometer. It's a new generation bilirubinometer which excludes the impact of double maturity, melanin, and hemoglobin. We measured it on the forehead, sternum, and pubic symphysis. And after that, blood was drawn within 10 minutes, and serum bilirubin was estimated by Vandenberg method. It's a diazo-based method. And we got the following results. Comparing the baseline characteristics of the study population, the baby's gestation age ranged between 34 weeks to 40 weeks, and the mean postnatal age was 62 hours. Birth weight mean was 2.9 kg. Male-female ratio was 1.2:1. The mean transcutaneous values were 13.9, and the mean serum bilirubin values were 12.9. It was comparable. So we found a positive correlation between the transcutaneous values at forehead, sternum, and pubic symphysis with the serum bilirubin levels. Here we can see that in the forehead, the Pearson correlation coefficient, that R value is 0.7, which shows a strong correlation. And the values at sternum and pubic symphysis, we got an R value of 0.6 and 0.5, which shows a moderate correlation. In all these three cases, the P value was less than 0.001. This is the bland Altman analysis showing the linear correlation between transcutaneous and the serum bilirubin values. And we can see that linear correlation. The maximum correlation was found between transcutaneous values at the forehead and the serum bilirubin levels compared to those at the sternum and pubic symphysis. We also found a positive correlation between transcutaneous values and the entire range of serum bilirubin levels, but the correlation was maximum for serum bilirubin levels less than 10, moderate for values between 10 to 15, but for bilirubin levels more than 15, the correlation was very weak, 0.2 only. This is the Blanch-Altman analysis, again showing the correlation. We can see that as the bilirubin level increases, the correlation between transcutaneous and serum bilirubin levels are decreasing. The sensitivity, specificity, positive predictive value, and negative predictive value of the transcutaneous bilirubinometer in detecting pathological jaundice was 80%, 79%, 68%, and 88% respectively. There were some limitations for the study, like the total serum bilirubin levels were estimated by Vandenberg method rather than spectrophotometry or HPLC, which was one of the outdated methods. And the newborns were selected irrespective of the skin color compared to other studies where babies with uniform skin color were selected. Other factors affecting serum bilirubin levels like albumin, free fatty acids, hematocrit, etc. were not uniform in these babies. So to conclude, both forehead and sternum are optimal sites for transcutaneous bilirubinometry measurements, with a strong correlation for forehead values and moderate correlation for sternal values with TSB. In other studies done previously in 2007 by Lucia et al. And 2014, a recent study, they found more correlation for the sternal values. But some studies done in India, including AIMS, they have found equal correlation for both forehead and sternum. But now we got a correlation more for the forehead values. It was previously said that the forehead values are found to underestimate the serum bilirubin levels because of the exposure of the forehead to the room light. And there is only a weak correlation between transcutaneous values and higher bilirubin values more than 15, and a moderate correlation for values less than 15. Hence, the serum bilirubin should be done for planning the management when it reaches the phototherapy range. And transcutaneous bilirubinometer has a high negative predictive value according to a study in evaluating pathological jaundice, and the sensitivity is less compared to previous studies, but the specificity was comparable. These are my references. Thank you.
Thank you, Dr. It was a nice presentation. I just wanted to know first about your subjects. So did you look for, are you able to hear me?
Yes, sir.
Yeah.
It's okay.
So, yeah, while you are choosing your subjects, that is the enrolled babies, so all the babies whom you have checked the TCB were undergone TSB also?
Yes, sir. Yes, sir.
Even if the value is 5, 6 also, what is your unit protocol?
So actually, we chose babies who had icterus from zone 3 onwards. Clinically, for such babies, anyway, we were doing this serum bilirubin level, so we checked the transcutaneous also along with that.
Okay. And second one is that how did you calculate your sample size?
So sample size based on that, assuming that the incidence of jaundice of 60% in the term babies, we calculate the samples based on that that equation, that 4PQ by R square.
Okay. Yeah, Sindhu. Thank you. Next, Anish, you want to take?
I can't hear.
Unmute.
Sorry. Yeah. So very good presentation. I just had a question. What is agreement in this situation, and what is the difference between agreement and correlation? Because I heard you using correlation a few times.
So actually, I don't know the difference. Like correlation means that correlation, the agreement. I don't know the difference, sir.
Okay. Because you use the Bland-Altman plot, no? So what is the main advantage over a regular correlation coefficient?
So like a normal correlation coefficient, we can, based on that value which we get at Pearson correlation coefficient, we can assess whether the correlation is perfect, strong, moderate, like that. And the Blanch-Altman, like for the visual assessment, we can easily find out the correlation. Only that much I know, sir, about that. Sir.
Thank you. That's all.
Thank you, sir.
Anupama, well presented, and you have explored the use of transcutaneous bilirubin. My question to you is that you have a wide range of population starting from 33 weeks onwards.
Yes, ma'am.
right? Did you look at these babies separately, less than 35 weeks separately and the term babies separately? Or?
No, ma'am. No, ma'am. We took them together.
Okay. Do you think that in preterm babies, the diagnostic validity of transcutaneous bilirubin is going to be less?
Because of that dermal maturity can affect transcutaneous values, because if the skin is thin, then there is chance for the values to get overestimating the serum bilirubin levels like that.
Okay, you can look at the preterm baby separately and see whether that makes any difference. And as Dr. Anish said, agreement might be a better way to find out because both of them measure the same variable, right?
Okay, ma'am. Okay, ma'am. Okay. Thank you, ma'am.
Nice presentation. I have two questions. This you have told about the correlation coefficients. Is a coefficient of 0.72 or 0.69, is that sufficient to adopt it for clinical practice?
So it's like less than more than 0.6, 0.7 constitutes a strong correlation, sir. So we got a strong correlation for the forehead values compared to sternum and pubic symphysis, where the correlation was moderate. So we can definitely adopt it for this clinical correlation. But if the transcutaneous values are going above 50, then we should definitely do the serum bilirubin also, because for higher values, the correlation with the serum bilirubin is very less.
So second question, in the real life scenario, what we will be doing? First, we will be doing transcutaneous bilirubin. If it is more than 13 or it is near the phototherapy cutoff, we go for the serum bilirubin.
Definitely,
so,
sir.
Yeah, did you assess how many pricks would have been avoided, like by using each of these sites? Like, for example, you assessed sternum, you assessed forehead, you assessed the other side also. So how many pricks would have been averted or excess pricks would have happened? Did anything of that sort was assessed?
No, sir. No.
It would be interesting to see.
Right. Okay, sir. Okay.
Thank you.
Thank you, sir.
Thank you, Anupama. We'll move to Vineet. Vineet, please share your screen.
So can you see my screen?
Right, sure. Yeah.
Good evening, esteemed panel of judges and my dear colleagues. The oral paper today is risk factors and outcome of ROP in a tertiary referral NICU at Malappuram district. It was a retrospective cohort study. As we all know, the incidence of ROP in India is increasing to around 38 to 51% because of the increased survival of extreme preterm babies and very high-risk babies. The classification and staging we have used in this study is of ICROP 2005. And as we all know, the pre-threshold and threshold ROP requires treatment. And prompt identification of pre-threshold type 1 ROPs will prevent progression to threshold ROPs and can prevent retinal detachment and other bad outcomes. I've defined type 1 and type 2 lower pre-threshold ROP because we have used this extensively in our study. The methodology. The aim of the study was to find the association of various risk factors in ROP and to assess the outcome of treatment of ROP in these babies. The study was done in a high volume center in Malappuram district. 223 babies with ROP were admitted in the tertiary care NICU were studied. The study duration was of 25 months from May 2017 to June 2019. And the study was done by the babies fitting the screening criteria. Were evaluated by personnel from Aravinda Institute using a REDCam. And the babies were evaluated at Coimbatore by the vitreoretinal surgeons. We have used standard statistical parameters like t-test and chi-square test to find significant association, and a p-value of less than 0.05 was taken as significant. Coming to the results, as it has been established in various other studies, the gestational age, birth weight, need for resuscitation, the need for surfactant administration, the duration and type of oxygen delivery, and the incidence of sepsis and blood transfusion were found to be associated significantly with, correlated significantly with the ROPs. The type 1 ROP, which is supposed to be more serious, were seen in, as expected, in lower gestational age with a mean gestation of 28 weeks gestation, a lower birth weight of 1.08 mean weight, And because of maybe because of the lower gestational age and more prematurity, the need for surfactant administration, resuscitation, and the oxygen requirement was much prolonged in these babies. The incidence of sepsis and blood transfusion was also much higher in these babies compared to type 2 ROPs. I've just highlighted the significantly correlated parameters. We had around 48 babies who were less than 30 weeks gestation. The need for resuscitation, which had positively correlated, the requirement was seen in 22%, and surfactant was administered in 20% of the babies, and the incidence of sepsis was in 14% of these babies. Blood transfusion administration was in 14% of these babies. The other parameters assessed were not significantly correlated since I have not highlighted. To come to the outcome, out of the 21 cases with type 1 ROP, 19 cases were treated with intravitreal injection of bevacizumab, and only one case required laser treatment. One baby expired postnatally. And the other parameters like antenatal steroid administration, PROM in mother, inotropic support, IVH, though they were correlating, the correlation was not significant. The type 2 ROP cases were followed up till the vascularization was complete. To conclude, the incidence of type 1 ROP in our study was 9.4%, which was similar to various studies published internationally as well as in our country. All these treated cases had good outcome and no case had visual impairment on follow-up. The type 1 ROP group that required treatment had a lower birth weight of 1.05 average and a smaller gestational age, average of 28 weeks. There was significant association between the need of resuscitation, surfactant administration, duration and mode of oxygen therapy, sepsis and blood transfusion with ROP with a p-value of less than 0.05. As we all know, ROP score is a validated, well-established score which can predict the incidence of type 1 ROP. And even in this study, we could have done that actually. And early treatment, treating oxygen as a drug, judicious use of blood transfusion, and sepsis prevention remains the most important strategies in prevention of blindness caused by ROP. Thank you.
Thank you, Vinit. It was a very nice presentation. I just wanted to take from your experience from this study, what is your conclusions to the other units? What are the things that they need to target? Modifiable factors, what are the modifiable factors to reduce the ROP?
So the modifier, coming to the antenatal things, the gestational age was found to be significantly associated. So to prevent preterm labor and antenatal steroid administration and to prevent preterm deliveries itself is very important. Coming to the labor room management, as we've seen, the need for resuscitation was positively correlating. So again, the antenatal steroids and other interventions which can reduce asphyxia and other problems at preterm deliveries will help in reducing the ROP incidence as such. Then coming to the postnatal management, the mode of oxygen delivery, oxygen should be treated as a drug. And though the lower limits are very strictly followed, the higher limits of oxygen in the alarms are usually we tend to ignore on that, and it should be maintained at less than 95. And the other things is prevention of sepsis and judicious blood transfusion. As we have seen that it was in our study also, it was significantly correlating with the incidence of ROP. And blood transfusion, we need to have a higher threshold. And we need to prevent sepsis, and all the normal precautions need to be taken while handling the babies.
Thank you. Thank you. Next.
Thank you, sir.
Good presentation, Vineet.
Thank you, sir.
Can you just clarify what was the inclusion criteria? Babies with ROP, what was the?
So the inclusion criteria was the standard criteria which we're using. The gestational age less than 34 weeks or the weight of less than 2 kgs. After a period of 2 weeks, after a period of 2 to 3 weeks, we were evaluating these babies. And any babies which had significant risk factors like asphyxia, need for resuscitation, or other risk factors, then even these babies were evaluated based on the discretion of the neonatologist.
And was injection Avastin the first line of treatment, or was laser the first?
Sir, injection Avastin was the first line of treatment, though the ETROP study doesn't recommend that as the first line. But based on the comfort level of the vitreoretinal surgeon, I think it can be decided. So we were using Avastin as a first line, and only one baby who had not responded to 2 doses of Avastin required diode laser therapy.
Okay, thank you.
Thank you, sir.
Rajendra, you can ask.
Okay, good presentation.
Thank you, sir.
I have two questions. How did you ensure that you collected all the data, like missing data? How did you ensure it is minimized? What is the source of data collection?
So we have a database of all these babies because since it is a RedCam based test we were doing in the unit. The Aravind Eye Hospital is also maintaining a database. So, and we could ensure that these babies were followed up on time, and we maintain a proper database. Actually, the 223 babies we had selected were actually almost, except that one baby who had died, all the babies were on proper follow-ups.
Okay. When presenting the results, I found that you have mixed the baseline characteristics and the postnatal characteristics. Ideally, they should be presented separately, and we can do a regression analysis based on the factors you are mentioning.
Yes, sir.
Antenatal choriamnitis, antenatal steroids, birth weight, gestation. They should be adjusted when we see what postnatal factors are exactly resulting in the ROP.
Yes, sir.
Okay.
Thank you, sir.
Well presented, Vineet.
Thank you, ma'am.
So this is the study duration is how much? You had collected 200 odd babies with retinopathy over what period?
Ma'am, it is 2 years, ma'am, from May 2017 to June 2019, 25 months, in fact.
Okay, so it's a huge number of babies with retinopathy, isn't
Yes,
it?
ma'am. Yes, ma'am.
Yeah.
Ma'am, the annual turnover is more than 1,000 admissions in INACU, ma'am.
Okay.
So,
okay. So
the incidence.
what is the duration of follow-up? Once you give Avastin,
Yes, ma'am.
how long do you need to follow up these babies?
Ma'am, again, till the retina matures completely, ma'am, following the administration of Avastin. Ma'am, exact duration, I'm not sure.
Compared to laser, there is a high risk for recurrence if you use Avastin. So they need longer periods of follow-up. So some of these babies might end up receiving laser also. Avastin has a specific indication. Even not all type 1 ROPs qualify for Avastin treatment. So that needs to be looked into, and these babies need to have a longer follow-up so that recurrence is. So follow-up outcomes, ophthalmological outcomes are also important in these babies.
Yes, ma'am.
Thank you.
Thank you, ma'am.
Okay, thanks, Vineet.
Thank you, sir.
Now we'll move on to the next candidate, Monica. Dr. Monica is there. Can you please share the screen? Dr. Monica? Dr. Monica, your sound is not audible. Dr. Monica, are you hearing me? Dr. Monica, hello. We'll move to the next candidate then. Navanita. Dr. Navanita.
Yes, sir.
Can you please share the screen?
Yes.
Yeah. Okay.
Sir, am I audible?
Yeah, you are audible. You can start screen sharing.
Yes, sir. see my screen?
Yeah, we can see. We can see.
Yes, sir. Yes.
Fine. Good.
Hello, everyone. We have studied this. We have made this study so as to see as HSS as the marker of neonatal sepsis. I'm Dr. K. Navneeta from NICE Hospital. I am neonatology fellow in trainee, Hyderabad. As we all know that neonatal sepsis is a significant cause of morbidity and mortality in neonates in developing countries. Incidence being 30 of the 1,000 live births, and this accounts for about 30 to 50% of the neonatal deaths in developing countries. As the features of the sepsis are non-specific, a high incidence of suspicion has to be entertained for its early diagnosis. As we all know that blood culture is a diagnostic gold standard for the diagnosis of sepsis, but its problems are time consuming and it's expensive, and 30 to 50% are gives the positive results. So we thought of like going for HSS as an alternative surrogate marker for predicting the neonatal sepsis. The advantage of this HSS is it's cost effective, readily available, and we get the quick results. The hematological scoring system contains 7 things, that is total WBC, total PMN, immature cells, IT ratio, IM ratio, degenerative changes like toxic granules, cytoplasmic vacuoles, and platelet count less than 1.5 lakhs. Scores when they are less than 2, it's low risk, 3 to 4 moderate, and scores above 5 are high risk. So, is HSS an effective early surrogate marker of neonatal sepsis? So, we thought of like assessing the efficacy of HSS and other clinical or the laboratory markers in the early diagnosis of the neonatal sepsis. We have included all the NICU admissions with risk factors for sepsis. And these are the risk factors. They are divided into antepartum, natal, and neonatal as shown in the slide. Exclusion being the patients who took LAMA and unwilling parental unwillingness. It's a retrospective cohort study done in our NICU NICE hospital for the duration of 1 year with diagnosis of suspected, probable, and culture positive sepsis. Our total admissions were around 680, of which 1/3 were septic patients. Of them, recruited were 190. This pie diagram shows the division. 64% were suspected sepsis, 29 were probable sepsis, and the rest are culture positive sepsis. This pie diagram shows inclination towards the male predominance over the females, but there was no gender significance in this study. This is the distribution according to the gestational age, of which around 60% were preterm, of which around 60% were late preterm babies. This is the bar diagram representing the same. And we have taken the predictors of neonatal sepsis, and we have like indicating the univariate analysis. We have done the univariate analysis, of which the significance was shown in early preterm, perinatal asphyxia, mechanical ventilation, poor feeding, lethargy, poor perfusion, apnea, positive CRP, and HSS. We have considered even other factors also, but they were not significant, so we didn't include. This is the multivariate analysis, of which positive CRP and HSS more than or equal to 5 showed the significance. This is the comparative one, univariate and the multivariate, of which positive CRP and HSS were standing out significant. This is the ROC curve. And this is the slide summarizing the univariate analysis and the multivariate analysis, which I discussed just now. And our study concluded that HSS score more than or equal to 5 is an effective surrogate marker, both alone and in association with lab markers like positive CRP. This may help in decision making of timely administration of antibiotics in an ICU. But the limitations for our study were large sample size along with high representation of blood culture positive patients would have enhanced the findings of the study. Thank you.
Over to judges.
Dr. Namita, one of the important topics that you have touched right now, I just wanted to know, you have a lot of parameters in the HSS also.
Yes, sir.
You have retrospective analysis. Okay.
Yes.
What could have been your limitations in this study? What could have been your confounders just because you had done a retrospective analysis? One thing. And second thing is that you have taken the gold standard as CRP level. So what is the CRP level that you taken?
More than 6, sir.
What is the standard in your unit?
Sir, 6.
Is it 6 per deciliter or 6 per liter?
6 per deciliter.
Okay. So, to the first question, any answer from your side?
Yes, sir. We have multiple co-founders with this. We have considered a lot of predictors for this, but they had no significance regarding this. All the things regarding the GIT, renal, and everything we have considered, but they had no significance with this.
Okay, Anish.
Hi, Namita.
Hello,
Can
sir.
you tell me what is negative predictive value and how does it help in decision making at the bedside?
Right now, I couldn't remember the definition, sir. Sorry.
Okay, no problem.
So we have compared this hematological scoring system score of more than 5 against CRP. So did you compare against the gold standard of blood culture? What is the sensitivity and specificity of the score more than 5 to detect a culture positive sepsis? Because in the gold standard has to be culture positive sepsis. We cannot take CRP as a gold standard. It is one of the other tests. So did we compare against the blood culture results?
No, we haven't compared, but we have taken the data, sir.
Okay.
Our study was meant to highlight HSS in this.
Okay.
Navneeta, thanks for the presentation. This is your score is similar to any of the sepsis screens. How is this different? We have a lot of data telling us about the role of sepsis screen in diagnosis of sepsis.
Yes,
how is
ma'am.
your study different?
But in this, we have included all the rest of the parameters, ma'am. Like we have included the platelet count, all like immature neutrophils with comparison of the ratios and everything.
Okay, thank you.
Thanks, Navneeta.
Thank you, sir.
Dr. Monica, are you there? Can you please share your screen?
Sir, can you hear me?
Yeah, yeah.
Yes, sir.
Audio is good.
Yes, sir. Can I start, sir?
Yeah, please start.
Yeah, good afternoon, everyone. Today, my project is role of myself. I'm Dr. Monica from NICE Hospital. Today, my topic being role of platelet indices as a predictor of sepsis and mortality in NICU. Neonatal sepsis is a disease process which represents the systemic response of bacteria entering the bloodstream during the first 28 days of life. It is a very serious condition, and if it is not diagnosed and treated quickly, can lead to shock, multi-organ dysfunction, permanent disability, or death. Globally, of the 3 million annual neonatal sepsis cases, India has the highest incidence of clinical sepsis. The case fatality rate of sepsis among the neonate ranges between 25% to 65% in India. To diagnose sepsis, blood culture is a gold standard, but it is expensive, takes time to get the final report. Mean platelet volume, platelet distribution width, and platelet grid has been the subject of intensive study in the recent years. The present study was therefore taken to assess ability of platelet indices at admission to predict sepsis and mortality in the neonates. Coming to the materials, we have done an observational cross-sectional study who are admitted in NICU. Study period being September 2020 to March 2021. Total admissions being 442. Coming to the inclusion criteria, all the hospitalized neonates in NICU whose complete blood picture is indicated within 72 hours of admission. Coming to the exclusion, we have taken the major congenital anomalies, refusal of consent, neonates not tested for the platelet parameters. After applying the inclusion and exclusion criteria, 119 neonates were selected and informed consent was obtained from their parents. Complete blood picture done within 72 hours of admission, demographic data, clinical background data collected from the records, clinical investigations like mean platelet volume, platelet grid, platelet distribution width were done, and morbidity and mortality were noted down by the medical records. Based on the demographic, clinical, and laboratory parameters, every test was univariate analysis, and those significant were used to construct on the multiple variant. Coming to the results, we have, as per the patient characteristic gender, we have 63% of males and 37% of females. Coming to the birth weight, we have the low birth weight being the maximum of 65%. And coming to the growth assessment at birth, we have age for appropriate was 95 and small for gestation being 20, large for gestation being 4. Coming to the gestational age, we have late preterm being 38 and term being 43. And as per the analysis, platelet indices and culture positive sepsis, we have found out to have 9 culture positive sepsis within the study period. Coming to the multi-univariant, we have all significant, whereas the platelet indices, the platelet distribution width, and platelet count less than 1.5 lakhs being significant. In the multivariant, we have platelet count less than 1.5 and CRP being positive. Combining both the univariant and the multivariant, even though the CRP is being positive is a significant, in the platelet indices, platelet count less than 1.5 as shown the significant factor. This is the ROC curve, which is suggesting of sensitivity and specificity. Whereas as per the mortality, the platelet indices and the mortality, we have 7 mortality within the study period. And coming to the univariant analysis, all the multiple factors we have univariant analysis significant. Coming to the platelet indices, platelet crit less than 0.15 as a significant factor. In the multivariant, we have platelet, again the platelet crit less than 0.15 as a significant factor. Combining both, we have a significant factor of platelet crit less than 0.15 as a significant. This is the ROC curve again based on the neonatal mortality. And coming to the discussion part, the platelet distribution width was statistically significant in predicting blood culture positive sepsis in univariant analysis, but lost significance in the multivariant model. Out of the platelet indices, both in the univariant and the multivariant logistic regression analysis, platelet crit less than 0.15 with the odds ratio being 32.7 was associated with the mortality. Conclusion, our study found out that although the platelet distribution width was associated with culture positive sepsis in univariant analysis, none of the platelet indices was significant in predicting culture positive sepsis in the multivariant analysis. Low platelet crit was associated with increased mortality of neonates. Our study may help in early prognostication of sick patients in the NICU. These are my references. Thank you.
Thank you, Monica, for a nice presentation. I just have only one question.
Yes, sir.
How did you standardize your reporting of platelet indices?
We have taken as per the references ranges from the standard books and the other references articles, sir.
Standardization of reporting standardization. So how does your lab and you people have standardized so that there, because lab errors could be there, no?
Yes, sir.
So how did you ensure that there is no errors?
I'm sorry, sir.
Good, Anish.
Thanks for the presentation. My question also is related to the platelet indices. Did it add to the cost, and who bore
No,
the
sir.
cost of
It
all
was
of
the
that?
same because we initially, when the baby got admitted, we'll be doing the complete blood picture. That's the reason we have taken the babies who have been admitted within the 72 hours, not the babies who are for 24 hours or not done any investigations. So the initial complete blood picture count itself, we have asked for the platelet indices. There is no significant, no cost effective for the patients.
And it was automated, or it was done by somebody?
It's automated, sir.
So good presentation.
Yes, sir.
The inclusion criteria is not very clear. Is it the risk factor for infection, or their eligibility for having a hemogram?
Means like our basic study was based on the sepsis, sir. So within 72 hours, if in case the baby been outside born, so we would not consider it. So once the baby come within 72 hours, we used to take the included in the babies.
So this is only for early onset sepsis?
Most, yes, sir.
And you have shown two ROC curves.
Yes.
So that was not very clear what we are comparing.
Because we have very small sample size, sir. If that could be the reason.
Okay.
So, Monica?
Yes, ma'am.
There are a number of, thanks for the presentation first. There are a number of factors which can lead to low platelet count and alter platelet indices. Did you look for them, and what were they?
We have
Other
taken
than sepsis.
Yes, ma'am. We have taken like mechanical ventilation, BPD, intraventricular bronchopulmonary dysplasia, interventricular hemorrhages, pneumothorax, and ROP, and all these factors. But they were not so suggestive of much.
Maternal non-infectious conditions,
Yes,
fetal infectious conditions, which can cause abnormalities in the platelets. Did you look for them?
Yes, ma'am. We have taken maternal infectious also, ma'am.
Okay, thank you.
Thank you.
Thanks, Monica.
Thank you, sir.
So we'll move to the next presentation. Dr. Arif, please share the screen and start presenting.
Good evening, respected panelists. Good evening, respected panelists. My paper is Early Intravenous Phosphorus and Bone Safe Bundles in Preterm Infant. Is it a game changer? This slide showing the complex process happening in the fetal life where the bone mineralization is happening. For this, calcium and phosphorus is very essential, and this is happening in the last trimester of the pregnancy. We all know that the incidence of metabolic bone disease is inversely proportional to the prematurity. So we need to supplement calcium as well as phosphorus for the baby to prevent or to decrease the incidence of metabolic bone disease in preterm babies. Even though in our country, the extreme preterm babies, the survival is at par with the Western world, our early phosphorus supplementation is not at par with Western world because they have got a pharmaceutical preparation which can be given along with the parenteral nutrition. In India, our this early phosphorus supplementation is not that optimal in that context. And the next problem statement was, can we introduce human milk fortifier, which is a good source of phosphorus and calcium, and it can be given for the babies at a quite early during the early itself. And can we optimize the phosphorus levels before by 4 weeks of life? After completing our study, what we have found was we have been giving early intravenous potassium phosphorus salts supplementation along with the parenteral nutrition, and we have been able to add human milk fortifiers quite early, that is by around 40 ml per kg per day feed if the baby is tolerating. And we have been found a significant reduction in the incidence of metabolic bone disease. For the metabolic bone disease, our definition was biomarkers of bone disease like phosphorus and ALP, where this phosphorus level is less than 5.5 or the ALP is more than 800. What we already know regarding the incidence of metabolic bone disease. This is a published study last year from our own unit regarding the incidence of metabolic bone disease, where we are following an early optimal nutrition strategy, where the incidence was 30% among less than 32 weeks of gestation. An aim of my study was to study the incidence of MBD in neonates less than 30 weeks on early and optimal phosphorus supplementation. And the objective was incidence of biochemical MBD using biomarkers at 4 weeks of life. And secondary objective was, since we are giving IV pot force, to analyze the incidence of hyperkalemia or hyperphosphatemia, which is very, very dangerous for these extreme preterm babies. And what we did, our unit is a level 3B NNFI accredited unit, and we done a prospective observational studies during the year 2020 and 21. And the exclusion criteria were babies having impaired renal function as well as surgical babies. And the eligible babies were 45 babies. These babies were less than 30 weeks and less than 1.25 kg in birth weight. And what we did, after 48 hours of life, we could be able to add intravenous port force along with the parenteral nutrition in the IV fluid. And we monitored the daily monitoring of phosphorus and potassium. And after, when the baby reaches 40 ml per kg of feeds and baby is tolerating, we could able to add human milk fortifiers to feeds. And then what we did, daily monitoring of phosphorus we did until the baby is getting IV port force. Then we monitored weekly monitoring of phosphorus till 4 weeks. And every week we will monitor the phosphorus and we will optimize with other supplements. And we diagnosed the diagnosis was done at 4 weeks of life using the biomarkers of MBD. What we found, the mean gestational age of our population was 28 weeks with standard deviation of 1.72, and mean birth weight was 1080 grams. Mean IV pot force days was 3, and mean days to full feeds was 6. Mean parenteral nutrition days was 4. And incidence of biochemical MBD was 6.2% among less than 30 weekers compared to 30% from our own unit previously. No, even though we are using IV pot force in these premature babies less than 30 weeks, we couldn't find any clinically significant hyperkalemia or hyperphosphatemia during our study period. And even though we are starting this human milk fortifier early, that is by around 40 ml per kg per day, and we couldn't find any clinically significant feed intolerance. Take home message and practical outcomes. We could be able to reduce the incidence of MBD, which was significant, and there was no significant adverse events during the study period. Thank you, sir.
Thank you, Arif, for a very crisp and nice presentation. One of the important and neglected topic that in your study. Two questions from my side. If you are given a choice to redo the study,
yes, sir,
what will be your best outcome that you want to choose?
Sir, DEXA scan, sir.
DEXA scan at what time?
Sir, 6 months to 1 year, sir.
Okay. Any other outcomes also you want to see?
Sorry, sir.
Okay.
Extrauterine growth, sir. Extrauterine growth. Linear growth of the baby, sir.
No problem. Okay. So second question is that you mentioned that while the baby is on IV phosphorus, that is IV pot phos, you check the phosphorus level at each day.
Yes, sir.
Okay. I think the sampling will be a major issue in these babies because you are choosing around 28 weeks of gestation.
Yes, sir.
If you observe any, because once you had choose this type of bundle approach, is there any increase in the blood transfusion rates or anything in the unit? It's just hypothetical.
No, we couldn't. No, sir. We couldn't find any increase in the blood transfusion units, sir.
Thank you.
Thank you, sir.
A very good presentation, Arif.
Thank you, sir.
How did you also run calcium, and how did you prevent calcium phosphate precipitation when it was
No,
running
sir.
through a common line?
No, sir. Actually, after 48 hours of life, we will remove the calcium from the this IV fluid, sir. We will be having this CBG value of calcium. It will be good enough. So we will remove the calcium. Then only we will add POD4, sir.
So, and how do you think that would impact the osteogenesis, removing calcium and then adding phosphorus?
Sir, by 48 hours or around our 3 to 4 days of life, our baby we will be supplementing with HMF also, sir. We'll be giving PDHM and HMF, sir. And we couldn't find any hypocalcemia after that, sir.
Okay.
Thank you, sir.
Good presentation.
Thank you, sir.
I have one question. Like, you have used a bundle
Yes,
to decrease the incidence of mineral bone disease.
Yes, sir.
So, how did you decide on each specific component of the bundle? Like, you have used IV phosphorus, HMF early. So, how do you know that these are going to work?
Sir, POD4 is a component where this 1 ml of POD4 contains 4.4 milliequivalents of potassium and 95 mg of phosphorus, sir. We will be giving phosphorus during the parenteral nutrition time. We will be giving 30 to 50 mg per kg per day of phosphorus, sir. In abstract terms, around 0.4 to 0.5 ml per kg of POD4 will deliver approximately 30 to 50 mg per kg per day of phosphorus, which is the natural accretion in the intrauterine life, sir, and that is where we are giving during the parenteral nutrition phase only.
Yeah, that's fine.
Okay,
My question is, how do you decide that only this intervention is going to work when you are designing your bundle?
Yes, sir.
So how
Sir,
did you come
for
to
that we
decision?
should have the sample size should be more, and we should conduct a randomized control trial, sir, where we should allocate two approach. Then only we can confirm that whether our interventions is good or not, sir.
We can adopt if someone has done that already, no?
Pardon, sir?
If someone has already done what you are telling, this RCT, that
sir.
can be adopted, no? So
Yes,
do
sir.
you have any evidence for IV phosphate administration and early initiation of HMF that they are going to decrease the NBD from other studies?
No, sir, I couldn't find, sir.
Okay.
Thank you, sir.
Thank you, Arif. Once again, a nice presentation.
Thank you, ma'am.
Bone bundle looks very interesting. I
Thank
have
you.
just one question. You had compared it with a historical cohort.
Yes,
and
ma'am.
said that your previous incidence of NBD was 30%,
Yes,
and
ma'am.
the post bundle it is 6%,
Yes,
right?
ma'am. Yes, ma'am.
That's a tremendous drop.
Yes, ma'am.
Which one of the bundle components no? So rather than a historical cohort, a prospective cohort or would have given a good idea about the existing incidents. And do you still continue to get just a 6% incidence? And is this bundle incorporated into your practice?
Ma'am, actually, this is currently going on study in our unit, ma'am. We are actually, our sample size is not at complete, ma'am. Till now, what we found was around 6.2%, ma'am.
Okay. Okay. Thank you.
Thank you, ma'am.
We can move to next.
Anu Sharma,
Yes, sir.
can you share your screen and start? Okay.
Not coming.
Anu, any problem is there?
Sir, just give me 1 minute.
Okay. Do you want us to share?
Okay, sir.
Okay, then we will share from here. Okay.
Okay, sir.
Okay. Anu, can you start?
Okay, sir.
Okay.
Good afternoon, dear judges. Myself, Dr. Anu Sharma. I am DM Neonatology Resident, SCT Hospital. I will be presenting a study entitled as Predictors Associated with Successful Closure of Hemodynamically Significant PDA with acetaminophen use in preterms less than or equal to 32 weeks of gestational age, a retrospective cohort study. Next slide. So as we all know, acetaminophen is increasingly used as for medical management of PDA, as it has been found to be of equal efficacy and less treatment-related immediate adverse effect when compared with indomethacin and brufen. But there is lack of literature evidence regarding the predictors associated with a successful closure of PDA with its use. So we present a retrospective study to provide new evidence to the predictors associated with closure of PDA with its use. So next slide, please. Our primary objective was to identify the predictors associated with successful closure of hemodynamically significant PDA with its use in preterms less than or equal to 32 weeks gestational age. And our secondary objective was to study the proportion of babies who had successful closure of PDA after receiving intravenous acetaminophen. Next slide, please. So it was a retrospective cohort study of less than or equal to 32 weeks gestational age preterm babies born from 1st January 2020 to 31st of December 2020 and found to have hemodynamically significant PDA on echocardiography and treated with intravenous acetaminophen as first-line treatment for 3 to 7 days. Next slide, please. So moving to our process flow chart, the data was collected from case records of the babies with gestational age less than or equal to 32 weeks after excluding those who had congenital anomalies, and the babies who had symptoms pertaining to hemodynamically significant PDA were further correlated on echocardiography, and those correlating on echocardiography were given IV acetaminophen as 15 mg per kg per dose, 6th hourly for 3 to 7 days. Further data was collected regarding closure of PDA, treatment failure, and those who had treatment failure were further followed up regarding surgical closure, spontaneous closure, and ultimately all our treatment cohort was assessed for overall outcome. Next slide, please. The PDA was defined as hemodynamically significant if features suggestive of pulmonary hyperperfusion or systemic hypoperfusion were there, or based on moderate to large size PDA with size more than or equal to 1.5 mm and additional echocardiographic findings in form of LA-AO ratio of more than 1.5, absent or reversal of flow in descending aorta or left ventricular dilatation. Next slide, please. And a successful closure was defined as no PDA or small PDA based on post-treatment echocardiogram using a definition less than 1.5 mm correlating with other echocardiographic parameter and with clinical resolution. Apart from this, data regarding gestational age, birth weight, sex, day of life at which treatment was started, duration of treatment, use of antenatal steroids, maternal chorioamnitis, RDS, need for mechanical ventilation, FiO2 required at the time of treatment, echocardiographic characteristics of PDA, and overall outcome was also assessed. Next slide, please. So we had 30 patients with hemodynamically significant PDA who received intravenous acetaminophen, and we found that 19 of our patients had closure, but 11 had treatment failure. Out of these 11, one patient had closure following surgery, whereas 2 had spontaneous closure, and 8 of our patients died in immediate newborn period. So further follow-up could not be done in these patients. Next slide, please. So to know the clinical characteristics in our patient, we looked for certain parameters as gestational age, birth weight, sex, antenatal steroid use, maternal chorioamnitis, RDS, mechanical ventilation, day of life at treatment, and FiO2 requirement at the time of treatment. And what we found that none of our parameters had statistically significant values, but we observed that patient with certain characteristics, next slide please, like gestational age more than 28 weeks, those who received antenatal steroids, those who had who were less than 7 days of age at the time of treatment, and those who had FiO2 requirement of less than or equal to 30% had trends towards more successful PDA closure. Next slide, please. And when these patients were further assessed based on PDA size and LA-AO ratio, we found that PDA size had no correlation with the significant PDA closure, but in LA-AO ratio, the patient who had a size of 1.5 to 2 mm, they had trends towards more successful closure, and 74% of our patient in this group had successful closure. Next slide, please. On further analysis, we found that in LA-AO ratio, the one who closed, the mean size was 1.773 with a p-value of less than 0.01 and confidence interval of 1.54 to 1.89. So only successful predictor we could get in our study was LA-AO ratio of 1.5 to 2 mm.
30 seconds more.
If we see for overall outcome of patients, we had 14 patients, that is 46.7% death in our overall patient group. Next slide, please. So predictors associated with successful PDA closure in study was LA-AO ratio of 1.5 to 2 mm. Echocardiography corroborated closure in 19 patients, and treatment was more successful when given within 7 days of birth. We noticed that patients with certain characteristics like gestational age more than 28 weeks, antenatal steroid use, and FiO2 less than 30% at treatment had trends towards successful PDA closure, but results were not statistically significant. None of our patients had adverse effect related to treatment, and we report an overall 46.7% mortality at hospital discharge in our patient. Next slide, please. To conclude, acetaminophen may be more successful in hemodynamically significant PDA closure with LA-AO ratio of 1.5 to 2 mm, and predictors such as gestational age more than 28 weeks, antenatal steroid use, and FiO2 less than 30% at treatment may confer successful PDA closure, but more studies are warranted. And overall, we report a lower successful PDA closure rate following acetaminophen treatment when using hemodynamically significant PDA closure strategy as our treatment. With this, I conclude. Thank you.
Thank you, Dr. Anu. I have two queries. One is that you have written that criteria for successful closure of the PDA. So is it 1 point assessment, or you have checked it how many times before you say that it is completely closed? Second one is that any clinical parameters also, did you look at it for the predictors? Because very few you mentioned some FiO2 0.3, more than 0.3 at the time of enrollment, and day of life, these were there, but any of the clinical findings like associated with the shock and not associated with the shock or anything, some of the other factors which are predictors for the PDA closure?
Sir, regarding shock and all, we have not assessed separately, but the babies who were actually clinically having features suggestive of pulmonary overcirculation or systemic hypoperfusion, those who were needing vasopressor for hypotension, these patients were treated with PDA in certain characteristics, but separately assessing data we had not done.
Regarding your outcome, successful closure of the PDA?
Sir, regarding actually our treatment protocol is we give treatment for 3 to 7 days, and based on clinical correlation, like if at 3 days we feel like the baby is improving clinically, there is a significant improvement, we correlate with the echocardiography also. And in case we are not getting a significant improvement clinically also, we repeat echo at 4 to 5 days to decide on whether we should need to continue treatment or not. And after 5 days, if still it is persisting, on day 7 we repeat it further. And in those who had failure, those who were not recovered, who had failure of closure at 7 days, further echoes will be done in these babies to know the further status, whether they will be just needing a normal follow-up or they need a surgical closure.
My question was that regarding successful closure of the PDA, is it a single point of assessment or multiple times did you check it?
Sir, it is over that 7 days period. It is from 3rd to 7 days. It's those 4 days multiple times we assess.
Okay, thank you.
Hi, Anu. Thank you for your presentation. I had one question about your treatment. So if the treatment failed, it was a second course of acetaminophen or any other medication considered before surgical closure?
No, sir. Actually, we give for 7 days, our treatment protocol is we give up to 7 days acetaminophen. And if the failure is there, at current, our protocol is not to treat with the second line drug. If baby is having significant features needing persistent respiratory support or having hypotension or all features suggestive of clinically significant PDA with treatment failure, we go for a surgical closure.
Okay. And secondly, you mentioned that the LA aortic ratio was significant, right, in terms of determining closure. So what statistical test did you use to get that p-value?
Actually, sir, it was done as univariate analysis because we could find only one parameter that was showing statistically significance.
So what test was used?
Sorry, sir.
What was the statistical test that you used for getting that p-value?
Actually, for categorical variable, we had assessed the data with frequency and percentage, and for continuous mean and standard deviation. And then further, we had used that standard deviation plus that mean that we could get with plus minus 2 standard error that we had to check the confidence interval.
So thank you for the presentation, Dr. Anu. My question to you is that you said that you treated with paracetamol for a duration between 3 to 7 days. Would that have impacted the incidence of PDA closure? Some babies might close early. So which babies, how do you decide the duration of therapy?
Ma'am, our protocol is 3 to 7 days. On 3rd day, we will be doing a repeat echo, and those who have closure on echo and clinical improvement, we will be stopping a treatment at 3 days. And those who had no significant improvement and echocardiographic correlation, like parameters also persisting of hemodynamically significant PDA, we continue our treatment up to 7 days.
So the babies who had PDA closure,
yes, ma'am.
After how many days of therapy did it close?
Ma'am, 19 of our patient had closure. Out of these 19, 11 patient had PDA closure up to 3 days of therapy, and rest 8 required total 7 days.
Okay, thank you.
Good presentation. Your entire study rotates around this PDA size, various parameters. So being a retrospective design, did we have an uniform unit protocol in that 1 year or 6 months period where the study was done? And second question, how did we ensure that inter-observer variability was minimized? Because for such a study, the main disadvantage with the retrospective design is it is very difficult to ensure that.
Sir, for all the assessment for hemodynamically significant PDA was done by pediatric cardiologists to know the size, and if it was found to be significant as per them and symptoms correlating clinically as per neonatologists, then only the patient was treated.
And was the protocol for doing the echo and treating was uniform across the study period?
Our protocol is, yes, sir. We have changed our protocol since last year only. Initially, we used to treat if we used to find any features suggestive of hemodynamically significant PDA, clinically we were getting. But now it's if we are getting those features clinically correlating on echo, showing significant LA dilatation, LV dilatation, or retrograde flow in the descending aorta, and with the size, the cutoff of more than 1.5 mm, those patients only we have started treating.
Okay, thank you.
Thanks, Dr. Anu. We'll move to the next candidate, Dr. Ashwati.
Good afternoon, respected judges and friends.
You can press F5 if you want to take it.
Good afternoon, all. I am Ashwati from KIMS Hospital, Trivandrum. I am presenting the interim results of my study on basic life support training for parents of NICU graduates. We all have known fear at some time or the other, and I fear for my parents when I do things against my conscience. And most importantly, I fear the unknown when I do not know what to do in those situations. Out of hospital, life threatening events are rare, but do happen. And when it happens, what decides the outcome of this situation is the time of initiation of resuscitation, effective and correct resuscitation. The first responder in that case is mostly a layman. In case of an NICU graduate, it is going to be a parent or a caregiver. With that in mind, KIMS NICU has been training parents of NICU graduates on basic life support skills while they're getting ready for discharge. India is different in social aspects and family dynamics from high income countries. So families may react differently to such a training. For the same matter, there is no systemic studies from India on such training. Through this study, we could conclude that knowledge and effective skill transfer is possible and parents can be trained in BLS. This is a small video on how we train the parents. First, we introduce the need for training. In a one-to-one session, parent is demonstrated the skills on a mannequin. They are allowed to ask any number of queries, and later they are invited to demonstrate their skills on the mannequin. They are given a number of attempts till they become confident, but first attempt is considered a desired score. At the end of this training, we assess them on 3 domains of learning. So at this point, let me introduce to another aspect of relevance, that is domains of learning. There are 3 domains of human learning, that is psychomotor, cognitive, and affective. The psychomotor domain consists of the knowledge as well as the skills. Cognitive domain is the knowledge component, and affective is what one feels towards the topic. So in this study, we assessed them mainly on 3 domains, that is psychomotor. So there was an observation checklist. During the time when parent demonstrates the skills on the mannequin, we assess them based on an observation checklist. And 5 key points are identified. And the parent is expected to score 5 out of 5 check marks to get the desired score. And the secondary outcomes were the cognitive domain and the affective domain. The cognitive domain had 10 questions in a questionnaire, and 80% marks is expected as a desired score from the cognitive domain, and all 3 positive responses from the affective domain is considered a desired score. And the parents of NICU graduates planned for discharge were enrolled in the study. The sample size planned was 25. And once they are enrolled into the study, BLS training is administered and outcomes was assessed. While analyzing the data, we found that the mean age of parents was 32 years and the median gestation age of the infant at birth was 29 weeks and the mean birth weight was 1,152 grams. The 76% of them had no previous experience in BLS training, and the 88% of the parents scored 100% marks in the first attempt in the psychomotor domain. In the cognitive domain, 92% of them scored full marks at the first attempt, and in the affective domain, all of them responded positively towards the training. through our study, we could conclude that it is possible to train parents, even those with no previous medical training, in basic life support measures and demonstrate their psychomotor skills on a mannequin effectively. And none of the parents indicated any anxiety during learning or declined the session. Thank you.
Thank you, Austin. It was very nice presentation and one of the important topic that you have tackled in your study. I just wanted to know what are the challenges. Are you able to hear?
Yes, sir. Not very clear, sir.
Yeah. What are the challenges
Yes,
that
sir.
will be there when you want to scale up this type of training in the parents? Anticipated challenges will be there.
Yes, sir. One anticipated challenge was that how effective the skill transfer was. So, and what could be the media that can be used, whether showing on a mannequin or a video or maybe some, that was one anticipated challenge. And there were chances that they may overdo it if such a situation occur. So that was the challenge. And during this COVID situation, it was difficult to take extra precautions and use of 2 mannequins. So that was challenge.
As you are mentioning that sometimes they may overdo it.
Yes, sir.
How can you explain them and how do you prevent it?
So we can only train them adequately or explain them what are the points to look for to identify an unresponsive baby. So we hope to prevent such situations, but it is not completely preventable.
Thank you. Yeah, Anish.
Thanks.
Good presentation, Ashwati.
Thank you, sir.
Yeah, my question is that do you have any data in terms of how many babies from KIMS or anywhere, how many parents have had to do resuscitation at home? So is there a...
I don't have a clear data on that, but in our experience in KIMS, this was over 6 months. So one baby out of the 14 babies whom we had trained. So one parent had to do a resuscitation, and it came out well. Baby reached hospital on time and was resuscitated at home, and parents were happy about the training they received.
Okay, very good. And secondly, if you have to implement it clinically, this pilot project, what will be your inclusion criteria? Should we train it for all babies, or will there be a specific group of babies that you are more worried about?
It would be ideal to train all babies, especially those from the NICU. But to be precise, we would start with the infants who are at risk for life-threatening events, very low gestational age, infants, those who had any signs of encephalopathy during the NICU stay, or had a stomy course in NICU, or any congenital airway malformations. So those are the at-risk babies who will be trained.
Thank you.
Yeah, thank you, sir.
Very good presentation. So
Thank you,
I have one question. Did you assess what maternal factors are associated with a successfully trained mother? Like the mother's level of education or the socio-demographic factors?
Yes, sir.
Such things have been assessed by you?
Yes, sir. We had collected the data from the parents about their education status and their socioeconomic status also. And we had almost 90% of them were graduates. We didn't have education group below that. And because we had a selected group of people from KIMS Hospital, we had most of them with a medium socioeconomic status also, sir.
Becomes a challenge in generalizing your study findings, because in the other setups, especially the government setups, the situation may be exactly opposite.
Yeah, such studies has to be done on the other setups also to assess the effectiveness.
Okay, thanks.
Okay, thanks.
Thank you, Ashwati. This is a very interesting study.
Yes.
I would like to ask you 2 questions. One, what was the interval between your teaching and assessment?
assessment was done soon after teaching, ma'am.
So would it be, it would be more interesting or no valuable to note at the time of discharge or after an interval, right?
Yes, ma'am. We are planning further studies for assessing after an interval to assess how well they are retaining the skills. We are planning such studies.
Okay. My second question is, you said you also taught parents positive pressure ventilation, right? Or ventilation, did you teach?
No.
Breaths?
Breaths we have taught, ma'am. Mouth to mouth without any equipments.
Okay, okay, fine. Thank you.
Yeah, thank you, ma'am.
Thank you, Ashwati. We'll move to the next participant, Dr. Taslima. Please start sharing your screen.
Yes, sir. Am I audible?
Taslima.
Yes, am I audible, sir?
Yes,
Hello.
yes.
Hello, am I
Yes,
audible?
you are.
Okay.
Yes, you are.
Yes, yes.
Is my slide visible now?
Yeah.
Okay. Good afternoon, everyone. I'll be presenting our study titled Evaluation of Pain and Physiological Stress During Targeted Neonatal Echocardiography. Neonates in the NICU experience a lot of painful procedures a day. Chronic pain exposure can cause physiological stress in them and can have immediate or long-term effects. Targeted neonatal echocardiography has been a part of routine care in the NICU these days. Though a non-invasive procedure, we do not know whether it can cause pain or stress. With this background, we put forth a research question. Do neonates undergoing targeted neonatal echocardiography experience pain or physiological stress? We aimed to evaluate the pain using premature infant pain profile revised score and physiological stress in the newborns undergoing a TN echo. Our primary outcome was to compare the PIPPR score before, during, and after a TN echo. Our secondary outcome was to compare the physiological parameters, that is heart rate, respiratory rate, oxygen saturation, and perfusion index before, during, and after a TN echo. We also compared the PIPPR score and physiological parameters between term and preterm neonates. For this, a prospective observational cross-sectional study was conducted in a tertiary care level 3B NICU from October 2020 to February 21 after the approval from an institutional ethics committee. All eligible neonates satisfying the inclusion criteria were consecutively enrolled. We included all the neonates that would undergo a TN echo in the unit for indications like HSPDA, PPHN, and shock. We excluded those neonates with severe perinatal asphyxia, neonatal encephalopathy, major congenital malformation, and those babies on drugs that could cause a CNS depression. A PIPPR score includes 7 variables, and if the total score is less than 5, indicates there is no pain. A moderate pain if the score is between 6 to 10, and severe pain if it is more than 10. When the clinical team decided to perform a TN echo, a written informed consent was taken from the parents. 30 minutes before the examination, we made sure that the neonates were not exposed or subjected to any interventions. Alarm sounds, if any, were decreased. Nauseous stimuli, if any, were minimized. A jelly was pre-warmed before a senior neonatologist would perform the echo. 10 minutes prior to the TN echo, physiological parameters, that is heart rate, respiratory rate, oxygen saturation, and perfusion index was recorded. The behavioral score was recorded on a video device, that is a smartphone, for a 30-second duration, and BP was also recorded. During the TN echo, physiological parameters and behavioral score component was recorded. 10 minutes after the TN echo, physiological parameters, behavioral score, and BP was monitored. For assessing the PIPPR score, the highest heart rate, lowest saturation, behavioral score, and state was recorded, and the data was analyzed using appropriate tests. 97 neonates underwent the TN echo during the study period, of which 88 neonates were enrolled, and the data was analyzed. Our baseline characteristic included a birth weight mean, which was 1758 grams, a gestational age of 33 weeks. Our primary outcome was to compare the PIPPR score So in this, we found that the mean and standard deviation of the total PIPPR score was higher during the echo, and also the individual components of the PIPPR score was increased during the echo as compared with the before and after. Amongst the physiological parameters, we found that the heart rate, respiratory rate was increased during the TN echo, and the saturations and perfusion index was decreased during the TN echo. The blood pressures were comparable. When we compare the physiological parameters between term and preterm neonates, we found that the heart rate was increased during the echo in the preterm neonates, and also the saturation was decreased more in the preterm neonates as compared to the term neonates. The BP and the perfusion index did not have any changes. When we compared the PIPPR score between term and preterm neonates, we found that in the preterm neonates, the PIPPR score was 1 to 2 points higher as compared to the term neonates, and also they were higher before, during, and after the TN echo. So in our study, we found a significant increase in the total PIPR score as well as a significant change in the physiological parameters. Similar style, which would indicate that there was a moderate pain and physiological stress in the neonate. Similar findings were also seen in a study done by Actors et al. In our study, we also found that the PIPR score was significantly higher in the preterm neonates, and also the heart rate and oxygen saturation was significantly higher and lower respectively. This could even be because the preterm neonates have a lower threshold for such pain.
1 more minute.
So to conclude, we can say that TN echo, though a non-invasive procedure, it does cause moderate pain in the neonates and physiological instability. So further RCTs are required to know the efficacy of pain relief measures in them. Our limitation of a study was that confounding factors like severity of illness and continuing respiratory support could have contributed to underscore and overscore the PPR. An exact time for these units to return to the baseline score was not studied. Thank you.
Very nice presentation, Taslima.
Thank you, sir.
So 2 queries from my side.
Yes, sir.
Does the duration of TN echo, that means that how much time it took for them to do a TN echo, does it matter? And second thing is that indication of the TN echo. That means that if the child was on shock, for a shock, if you are managing, then when you have done the TN echo, or just for screening a PDA, whether you have done a TN echo, whether it is different. Second thing is that who assessed this PIPPR scores and how did you standardize them, and was there any mechanism to look for the errors and other things? Thank you.
So for the first question, sir, as I've already said, that there were confounding factors. Like if the baby was an inotropic support, we did not consider that initially when we had included them. Also, for the duration of the 2D echo to be done, we had done it by a senior neonatologist so that the duration would be less and the baby is not exposed to a longer time. But we do not know that sometimes the duration could have been increased and that could have also confounded our study result. So second question, if you could repeat, I forgot.
So who measured this PIPPR scores? And if there are many people, how did you decrease the inter-observer errors? Was there any mechanism to standardize them?
So the PIPPR scores, sir, we had recorded them, and for the behavioral scores, so that there is no discrepancy, we had done a video recording so that one person could just analyze it, and we did not standardize it as such, sir.
Thank you. Yeah,
yes, sir. Thank you, sir.
Good presentation, Taslima.
Thank you,
my question was related to any pain control measures that was done. So midway through the study, you all noticed that this is painful procedure. So was anything introduced to sort of reduce that?
Yes, so after the procedure was done, we made sure a nesting was done or containment was done, or non-pharmacological measures like breast milk to given to the baby, or NNS was provided to the baby, sir. But after the procedure was done, we did.
Okay, not before or during the procedure.
No, it would have created some factors. It would have, no, we did not do it at that time.
Okay, thank you.
Thank you.
Good presentation. So,
Yes, sir.
but my basic question is, why did we assume that echo would not cause pain? Like, why do we have to do this study to prove that
So,
echo is painful?
okay. So whatever literature review that we had done, we hardly found one study which said that it may cause in preterm neonates. We do not know whether, because it is a non-invasive procedure and being increasingly used now, we always consider the non-invasive procedures do not cause pain. So that is why we did the study, sir.
And second question, there could be some other factors which could be influencing the pain perceived by the neonate. For example, you have told about the environmental, like light and sound. So did you account for other factors like when was the last feed given? Was the child on oral feeding or not?
So for any, so that is what we did, sir. Before we thought about starting the echo, we made sure 30 minutes before the examination that any noxious stimuli to be reduced or minimized, and any intervention like feeding or just handling the baby or giving putting an IV catheter, IV line, they were all. We made sure that no intervention was done at least 30 minutes before this.
Okay.
Thank you, Taslima, for the nice presentation. I do not have any questions for you, but anyway, thank you so much.
Okay, thank you, ma'am.
The next presentation can start.
Vishnu, Dr. Vishnu, can you please share your screen and start presenting?
Yes, sir. Am I audible, sir? Hello, am I audible, sir?
Yeah, you can start.
Okay. So, good evening, judges. I am presenting my study titled Transfusion Requirements in Preterm Neonates Before and After Implementation of Blood Conservation Strategies. So, preterm birth and preterm care forms an important part of the NICU care, and they often need multiple blood draws for frequent monitoring and also for guiding their care. And this can lead to their anemia, that is decrease in hemoglobin, and we often order transfusion when the transfusion criteria are met. And despite the advances in the management of anemia, allogenic RBC transfusion remains the primary modality of treatment in anemia in newborns. So transfusion in neonates is associated with many adverse reactions like transfusion reactions. Mismatch can happen, fluid overload, transfusion associated lung injury and gut injury, and also the transfusion associated infections like CMV and other associated infections. As per studies, it has shown that the extremely low birth weight babies, 90%, and very low birth weight babies, 58%, receive at least one transfusion during their infancy. And there is also associated risk of increased intraventricular hemorrhage, BPD, ROP, NEC, mortality, and other adverse neurological outcomes in those preterms receiving transfusions. So our study is tried to compare the transfusion requirements in preterm neonates before and after implementation of a combination of blood conservation strategies. So our strategies included implementation of point of care testing, capillary sampling analyzer, and also following the delayed cord clamping, and also stringent sampling measures to decrease the sampling by clubbing of samples, and also keeping a blood loss chart. So we tried to compare this transfusion requirements in preterms less than 30 weeks, less than or equal to 30 weeks gestation. We followed up to a period of 44 weeks gestation for those who meet the inclusion criteria. We also tried to compare between the two groups the cumulative estimated volume of intensive care associated blood losses. Also, other morbidities like sepsis, bronchopulmonary dysplasia, intraventricular hemorrhage, ROP, requiring laser, and NEC stage 2 and above. The comparison of baseline characteristics of both groups, there is not much difference in the maternal hemoglobin and the antepartum hemorrhage incidence between the both groups. And also in the infant characteristics, the gestation, birth weight, DCC done, and also the first hemoglobin reading significantly differ between both groups. So the primary outcome, the transfusion definitely decreased, and the number of transfusions per neonate, the median decreased from 1.2 to 0.2 after the implementation. And number of percentage of neonates recurring transfusion also decreased from 60% to 16%. And although not statistically significant, we can prolong the first transfusion by around 12 days from 22 days to 34 days. This is the Kaplan-Meier surveil analysis showing the that the time to even the first transfusion has prolonged by around 12 days. We also analyzed the different gestational age groups. As we can see that in the less than 28-week gestation age groups, the transfusion has drastically decreased from 100% to around 25%. And the 28 to 30 weeks gestation, it has decreased from 45% to around 5%. We also found out the drop in hemoglobin. The lowest hemoglobin has increased from 7.9 to 9.9, around 2, which was statistically significant after the implementation in the prospective group. And there was no, we couldn't find a we cannot find a prolongation in the day of lowest hemoglobin. That is in the retrospective group, it was mean was 44 days, and the prospective group, it was 36 days.
One more minute.
Yes, sir?
One more minute.
Okay. So postmortem day, it was 44 days. This could be due to those neonates in the retrospective group receiving multiple transmission in the earlier weeks of this postnatal days. And also, we couldn't find any significant difference between both groups. The adverse morbidities like sepsis, NEC, ROP, or intraventricular hemorrhage. And the calculated iatrogenic blood losses has significantly decreased after implementation by around 50%. That is the cumulative volume till discharge, and also cumulative volume per kilogram birth weight, because less than 50% in both groups after implementation. And also the this is the chart showing the comparison of investigation and associated blood loss. Blood gas, you can see that there is a increase in the trend towards doing the blood gas analysis, but there was no significant increase in the volume dose due to blood gas analysis.
Time is over.
And the lab investigations has significantly decreased because of what we are following the stringent blood loss measures. To conclude, blood conservation strategies definitely decrease transmission, and DCC can be done wherever possible, and we should follow a predefined transmission criteria. And reducing transmission probably drops the costs and also preserves resources and improves outcome. Thank you.
Thank you, Vishnu, for a good presentation. Just wanted to know why the delayed cord clamping is so low both in the both epochs.
Our gestation groups was those less than or equal to 30 weeks gestation. Most often these babies require resuscitation at birth, so it may not be possible to have delayed cord clamping in these groups. And also the evidence is less in those less than 28 weeks. It is not generally recommended.
Yeah, Nish, you can.
Just one thought regarding the cost. So what is the difference between the cost of a microsampling versus a regular electrolyte sodium potassium? Can you clarify in KIMS?
In KIMS, the capillary blood gas cost around 1,000 rupees. And the other one cost around 200 rupees.
Okay, so was this done as a QI project, or was it? Was the families consented for that?
Sir?
Was there any consent process involved because of the increasing cost, or it was just like a Q?
There was not much concern regarding costs.
Question was regarding consent. If it is done as a part of prospective study, have you taken the consent from the parents? Because Anish is telling that because there is a cost issue is there. Did we look at the change in the cost of the investigation, cumulative cost of investigations in the pre and post epoch?
Actually, with this, this point of care analyzer was implemented around 2 years back, and we are following it for all babies. The other laboratory ABG analysis we are not doing in our unit. No, only capillary sampling analysis we are doing for blood gas.
So it was implemented as a practice change without any consent. Okay.
Yes.
So good presentation. So I have one question. Along with the introduction of this micro sample analyzer, any other interventions were done during the period during this 2
along
years?
with that, we have done DCC was done, and also stringent sampling protocol, that is clubbing of samplings, and also keeping a blood loss chart, and following a strict protocol for routine investigations for preterm babies.
So is the study ongoing, or did we
This
complete
is
the
an interim data analysis. This is a result from interim analysis.
How did you select the comparison cohort in the retrospective?
Retrospective gestation age less than or equal to 30 weeks gestation, and those was admitted from outbound within 24 hours gestation to our unit, and
No, they were randomly chosen, or were they born over some particular period of time?
A particular period of time. We gone retrospectively from before the implementation of this capillary microsampling, retrospectively, and prospectively from after implementation.
So in the retrospective one, were you able to estimate the amount of sample that was drawn?
We have gone from the retrospective EMR data, and we could find out the investigations done, and we calculated from the number of investigations and sample required for each investigation.
Okay.
Thank you, Vishnu, for the nice presentation and doing work on this bundle approach. The questions that I have are: one, did your transfusion policy change during this time? Did you become more restrictive than before, or there was no change?
We tried to do restrictive transfusion. We follow the British BCSS guideline for transfusion in preterms, and we tried to stick to that transfusion guideline as far as possible. In the prospective
Pre-era and post-era, was there any change in the transfusion policy?
In the pre-era, it was not. We are not strictly following the transfusion guideline, but after the implementation, we are trying to follow this strictly.
Okay. Okay. And your primary outcome was the number of transfusions, right?
Yes, yes, ma'am.
Yeah, but they were not, the distribution was very skewed. You had presented the values as median and interquartile ranges, and right?
Yes, sir. Because most of the neonates may not get transfusion, and it ranges from 0 to 6.
Yes, yes. Okay, thank you.
Thank you, Vishnu. So now we'll move on to the last candidate, Dr. Anju. Can you please start sharing your screen?
Shall I start, sir?
Please start.
Good afternoon all. Today I would like to present my paper under the title Iron Status and Incidence of Iron Deficiency in a Cohort of Infants Born More than 34 Weeks of Gestational Age in a Tertiary Care Hospital, South Kerala. I myself, Dr. Anju Sebastian, under the guidance of Dr. Kamala Swarnam, Dr. Millie Thomas and Dr. Gobika Ashekar from Department of Pediatrics and Neonatology, Anandapuri Hospital and Research Institute, Thiruvananthapuram. Coming to introduction, as we know, anemia, which is caused by deficiency of micronutrients, especially iron, which is the most important nutritional problem in the world. And the highest prevalence is found in children below 5 years of age and pregnant women. And in developing countries, 47.4% of children below 4 years of age group are anemic. Till 6 months of age, breast milk is the only content or only source of iron, and the iron content of breast milk decreases steadily over the course of lactation. And there is increased need for iron from 6 to 12 months owing to the accelerated velocity of psychomotor growth and development, which depletes the reserve during this period if they are not adequately replaced. And very few studies have been done in India to assess iron deficiency anemia among term babies, that is early versus full term, and iron status among babies at birth and 6 to 9 months of age group. And most of the studies have been done among 6 to 60 months of age. And hence, in this context, we planned this study under the objectives: iron status among cohort of infants born more than 34 weeks of gestational age at birth and at 6 to 9 months of age, and incidence of poor iron status, that is iron deficiency and iron deficiency anemia among late preterm, early term, and full term babies. And we did, coming to methodology, we did this after getting ethical committee approval, and we did as a longitudinal follow-up study. All infants more than 34 weeks of gestational age born at our hospital during the study period January 2020 to September 2020, and they were followed up till 6 to 9 months of age. And sample size was calculated as 120 derived from the NFHS4 data. And relevant history, physical examination finding, and investigations were recorded and followed up. And the investigations included complete hemogram, red cell distribution with serum iron, serum ferritin, and total iron binding capacity at birth and 6 to 9 months of age, and babies with poor iron status among late preterm, early term, and full term. They were classified as iron deficiency and those with iron deficiency anemia. Iron deficiency we diagnosed with low serum ferritin and or low serum iron level, and iron deficiency were classified according to WHO criteria for hemoglobin cutoff to diagnose anemia. Coming to our results, as we can see that at 40 to 72 hours of life, the mean hemoglobin among our study group was 18.19, and serum iron was 85.65, and serum ferritin 205.3, and total iron binding capacity was 285. And at 6 to 9 months of age, it was mean hemoglobin was 11.92, serum iron 61.66 with a standard deviation of 20.6, serum ferritin 362.52, and total iron binding capacity 354. And at 6 to 9 months, when we followed up these babies, we can see that out of these 99 babies, 27.27% were having poor iron status. And when we analyze the babies, among late preterm, that is 16 babies, 25% were having poor iron status, that is they were already on iron drops. And early term, out of 26 early term, 65.3% were having poor iron status and 10.52 among full term. And there was only 2% of babies had clinical features of anemia. So coming to discussion, there was not much difference among late preterm, early term, and full term baby in their hemoglobin level at birth. And when we compared our study with study done by Shukla A.K. et al. At Lucknow Medical College, the mean hemoglobin at birth in their study was 17.62, and in our study it is 18.19. So our study is comparable with the study done by Shukla A.K. et al. And at 6 to 9 months of age, when you take the study done by Dr. Anjali T.R. et al. At SAT Hospital, Thiruvananthapuram, we can see that the mean hemoglobin among babies with anemia in their study done at 6 to 60 months of age group, it was 8.35. And in our study among age group 6 to 9 months was 10.12. And in our study, out of 27.27% of babies with poor iron status, only 2% had clinical features of anemia, which is tip of an iceberg. The remaining 25.27 had had poor iron status with no clinical features of iron deficiency anemia. And they all had normal growth. This shows the importance of initiation of iron prophylaxis among children starting from 6 months of onwards itself, irrespective of normal growth on clinical examination. Hence, this is a unique study which analyzed the iron status at 6 to 9 months of age, which is a crucial period of anemia prevention. And hence, we would like to conclude that more than 1/4 of infants in this cohort had poor iron status at 6 to 9 months of age without clinical manifestations. In spite of being on oral iron drops, 25% late preterm had poor iron status, highlighting the need for periodic dose adjustments. And the high proportion of poor iron status in early term babies supports the assumption that they are prone for issues similar to late preterm and throws light on the need for extra iron supplementation, just like preterm babies. And the low proportion of poor iron status in term baby may be attributable to better maternal iron status and the positive outcome of delayed cord clamping practice. Limitation of study was sample size was calculated as 120, but due to COVID-19 pandemic, only 99 infants were followed up at 6 to 9 months of age and they were analyzed. Study was done in an urban setting, cannot be generalized in other population. And we recommend similar prospective study on large sample size, preferably multicentric study. And our parent study reference study include association between breastfeeding practice and anemia done by Dr. T.R. Anjali et al. And effect of maternal anemia done by Arvind K. Shukla. Thank you.
Very nice presentation. Two things from my side. One is that did you included the babies who are small for gestational age in your study? So that is one.
Sir, they were included. They were included. Only all babies more than 34 weeks were included. Only criteria was those who didn't give consent.
Okay. So the issue is that when you include SGA babies, there could be little skewing of the iron parameters in those babies. Second one is that did you look at any intercurrent between 0 to 6 months? There were any babies requiring any admissions, or were they on any requirement of treatment for any illness, especially the infections? Because one of the main problems for anemia is in the India is that infections also. Did you look at it?
Yes, sir. They were followed up during vaccination, and only a few babies required OP cases, seen as OP cases. None of them required IP admissions, sir, for infections.
Thank you.
Good energetic presentation. Did the study have any funding for all the blood tests that was done, or did the parents have to bear the cost?
Sir, it was around, we did it as an iron status, and it cost around 800 rupees, sir. So when we take the consent, we will explain the importance of iron and starting the iron early, and the need for iron in the baby. So most of them gave consent, and they paid the 800 rupees also, sir.
Okay, and secondly, what would be the ideal outcome if you had more resources for iron deficiency? What other outcome would be ideal for iron? What is the main concern with iron deficiency long term?
Long term. So like iron deficiency, actually in this we also diagnosed that before coming to iron deficiency anemia, there's a state called iron deficiency. So most of the babies were coming under this iron deficiency state. So if you catch those babies in that iron deficiency state itself and you start the prophylaxis, we can prevent them going to anemia state. So the side effects of iron deficiency anemia or the complications of iron deficiency anemia can be prevented if you start the prophylaxis as advised by Anemia Mukt Bharat at 6 months of age itself, irrespective of the gestational age.
And any impact on cognition or IQ?
Yes, sir. Even they have told that iron deficiency anemia can cause seizure also. Seizure, stroke, means as late complication, even anemia can cause seizure and stroke in babies also.
Thank you.
Thank you, sir.
Very nice presentation. So it is interesting to see that early preterms have increased incidence of anemia. So in the late preterm group, you were telling like 25% still are deficient. And did we make like any objective measure of their iron compliance, how they were receiving iron during their infancy?
Yes, sir. Most of them told that they are giving iron as we advised. And they are under regular follow-up. I only call them regularly. So they were all telling that they are under good compliance only, these babies.
And regarding the early term,
but due to COVID pandemic,
yeah.
maybe some would not have given the correct dose.
And in the early term babies, so were they initiated on iron supplements from 4th month or 6th month?
6 months, sir. 6. Like from our study, like we can conclude that we followed up at 6 to 9 months of age only, sir. So from this study, we got the conclusion that they are more prone for iron deficiency or iron deficiency anemia. So now we are planning to give for early term babies also, we are planning to start iron like late preterm babies itself.
So the age at assessment of hemoglobin, you told 6 to 9 months.
Yes,
so
sir.
was the exact age you would have written, no?
Yes, no, sir. Because due to COVID pandemic, we considered, we took the opportunity to do the sample at while they came for vaccination. That is 9 months. Most of them will be coming at 9 months for vaccination. Or though if they are coming for any other cause, at between 6 to 9 months, we considered them.
Yeah, that's understandable. So was the age at assessment, is it similar between the early term and term babies, or is it slightly different?
It was comparable, sir. Not much difference was there.
Okay. Okay, thank you.
Anju, thank you for the very nice presentation, full of energy. I have one question. Do you put term babies, term babies, do you start them on iron by 4th month or 6th month?
Ma'am, usually for term babies, what we are following is from 6 months onwards, we will start the prophylaxis based on Anemia Mukta Bharat. We'll start from 6 months only. But from the study, we got the result that early term babies are prone for iron deficiency anemia more. So after the study, we are planning to start for early term babies also, a little bit early, not waiting till 6 months. We are going to catch them early so that we can prevent the poor iron status among them.
Okay. Thank you, Anju.
Thank you. So we'll move on to the next session. That's a poster presentation. I would like to invite the judges, Dr. Swati and Dr. Bharati. And our first candidate is Dr. Dignesh. Dignesh, are you there? Dr. Dignesh?
Hello, sir.
Hello. Yeah. Can you please start sharing your screen?
Yes, sir.
Okay.
Is my screen visible, sir?
Yes.
Good evening, everyone. Myself, Dr. Dignesh. I'm a senior resident in the Department of Neonatology at MSc Medical College, Kolancheri, Kerala. Today, I'm going to present a poster on minor blood group incompatibility, the report of 2 cases which have recently encountered in our unit. The hemolytic disease of fetus and newborn, as we know, it is caused by the destruction of RBCs of neonates or fetus by maternal IgG antibodies, and their manifestation can range from mild self-limited hemolytic disease to severe life-threatening anemia. And the major cause being RH and ABO group, and the 3 to 5% cases can be because of the minor blood group also. Therefore, the mother with RH-D positive and non-B or AB blood group are likely to escape aggressive monitoring for hyperbilirubinemia. Though less frequent, these minor blood group incompatibilities can cause severe manifestations, including hydrocephalus and bilirubin-induced neurological dysfunction. So I'll discuss about case 1. It was a term 38 weeks, 4 days. Appropriate for gestation is male, referred from peripheral hospital with a TSB of 17.7 milligram per deciliter, 48 hours of life, and was born to multi-gravida mother who was 31-year-old with a blood group of A positive and had a history of pre-gestation diabetes mellitus and was on insulin. Her first pregnancy was 8 years back and was a term male baby delivered by normal vaginal delivery and had a history of sibling jaundice for neonatal hyperbilirubinemia, for which phototherapy was given. G2 was a first trimester abortion, and present child was delivered by LSCS with a birth weight of 3 kg, blood group of A positive. Both mother and baby were A positive, and the child was started on phototherapy at 10 hours of life with TSB of 13.7 and TSB of 17.7 and 48 hours of life. Despite of phototherapy, the TSB was rising, so infant was referred to our hospital for further management. As we can see here, this is the AAP chart of phototherapy at 10 hours of life. TSB was 13.7, whereas it is 48 hours of life was 17.7. So the infant was referred to our hospital, and this is the AP chart for exchange transfusion. At 48 hours of life, our TSB value was 20.3. The baby was further evaluated, and sepsis screen done was negative, but DCT came as 3 positive, and retic was 11.6%, with the peripheral smear showing the evidence of hemolysis. whereas G6PD and osmotic fragility levels were in normal limits. Infant was treated with double volume exchange transfusion, double surface phototherapy, and IVIG was given in view of DC3 positive. Hello?
1 more minute.
Yeah, and coming to the second case, it was a late preterm, 34 weeks, 2 days, AGA male with blood group O positive, born to multigravid mother with history of pre-gestation diabetes mellitus and hypothyroidism. The infant was 2 kg and was started under phototherapy at 48 hours of life. This is the nice chart at 34 weeks of gestation. As we can see, there was a rising phototherapy under rising TSB under phototherapy. This infant was evaluated for which, and DCT came as 2 positive in this, and retic was 3%, and the peripheral smear showed a mild polychromasia, and was treated with double surface phototherapy. Suspecting hemolysis, we have sent the mother blood, which was ICT, which came as ICT4 positive, and the antibody screening was done. We showed the which shows the presence of KEL, MNS, and P and Lutheran group. So we have sent the 11-cell antibody panel, which shows the presence of anti-M antibody. Coming to the discussion, we all know that RH is one of the most complex human blood groups and has at least 45 RH antigens, among which most of the importance are D, capital C, C, E, and E. And MNS blood group being the second most complex blood group system after RH, and this manifestation can range from neonatal jaundice requiring exchange transfusion to retirement and death. The conclusion of this, my poster, is that these minor blood group incompatibility, though they are underreported and frequently misdiagnosed, their presentation can range from asymptomatic to significant hyperuremia and connector arrest. Therefore, if we do antenatal detection of significant antibody titer in the mother, we can ensure timely management and prevent significant morbidity and mortality in the neonatal risk. Thank you.
Dr. Dignesh, that was an excellent presentation, and we know that minor blood group incompatibility is coming up as a very important cause of connector risk.
Yes,
so
ma'am.
my question to you is, what do you think is the incidence of minor group incompatibility, and do you recommend this as universal testing in all?
The incidence only being 3 to 5%. And but thing is that if we do antibody titer, because most of the European countries in UK, US, they are all doing for all the mothers, irrespective of the RS or ABO status. So if we do in all the pregnancies, then it is in units which are at risk, we can prevent the morbidity and mortality. Right. Because sometimes not only does these babies will have evidence of hemolysis, they can present in later gestation, later period of time also with anemia and all.
Okay. So after these two cases, are you thinking of incorporating extended testing into your system?
So we are trying to incorporate, ma'am. We are talking to our gynecologists and all, and we are trying to implement this.
Oh, thank you.
Thank you, ma'am.
Thank you, Dr. Dignesh. That was an interesting case presentation. I would just like to ask two things. That first, what screening are you recommending in your unit now? Now, you just mentioned that you are having talks with your gynecologist. So, what exactly are you planning?
All the mothers, if we are doing indirect womb test, and though irrespective of the RH and ABO status, we can find out whether there is incompatibility there or not.
Okay. And did you give any specific follow-up advice for these babies?
Yeah, we have given the specific follow-up, because the first case we have done the double volume exchange transfusion, and we have advised them to get a BERA done at 3 months of gestation, 3 months of age, and we are regularly following up. And as of now, both the babies are growing well and developing normal.
Okay. I think we can move to the next presentation.
Thank you.
Okay, I'm inviting Dr. Anupama S. Pillai. Anupama.
Yes, ma'am. Good evening all again. My name is Dr. Anupama, and the title of my poster is Favoring Newborn, Sepsis and Beyond. Very rare and interesting case series of primary hemophagocytic lymphohistiocytosis. HLH is a hyperinflammatory syndrome, pathologic immune activation, very rare in newborns with very high case fatality rate and poor prognosis. It can be either primary genetic due to autosomal recessive, common in consanguineous marriages, or secondary to infections, malignancy, or autoimmune disorders. So we are presenting 3 babies who presented to our department in the last 2 years to give an awareness about the diagnosis of HLH, which needs a high index of suspicion for babies presenting with sepsis-like features and poor response to antibiotics. The first baby is a term baby who presented with continuous fever from 8th day of life with firm hepatosplenomegaly. Initially, we suspected sepsis and started antibiotics, but baby was not responding to it. In view of the persisting fever and bicytopenia, we suspected HLH and found that 6 out of the 8 criteria was satisfied. Baby also had hemophagocytosis in the bone marrow. Genetic testing was not done due to financial constraints, and the baby expired on day 28 before planning bone marrow transplantation. The second and third babies were siblings, and the first sibling presented on day 12 again with high-grade fever, sicker than the other baby, with respiratory distress, firm hepatosplenomegaly, rashes, pneumonia, etc. This baby was also not responding to the antibiotics, and in view of the continuous fever and pancytopenia, we did the workup again and found that the 5 criteria of the 8 were satisfied with very high serum ferritin levels. This baby did not have any hemophagocytosis. Injection Dexa was started after consulting with pediatric oncologist, but the baby expired on day 20 and genetic study could not be done. The younger sibling of this baby presented on day 45 to the PICU with high spiking fever, hepatosplenomegaly, rash, and diarrhea during the COVID pandemic. Initially, they suspected multi-system inflammatory syndrome due to COVID, but baby was not responding to the antibiotics, IVIG, or steroids, and the history of the sibling came into light, and then they did the workup for HLH, and bone marrow also showed hemophagocytosis. Genetic study was done for this sibling, and a homozygous missense variation was identified on exon 19 on chromosome 19, suggestive of XTXBP2, that is syntaxin binding protein 2 mutation, which is suggestive of HLH5. Both the parents were also heterozygous for this mutation, and the baby expired, and the prenatal diagnosis was advised for the next pregnancy. So we can see that out of the 3 babies, the younger, the 2 siblings and the younger sibling found this mutation, and the parents were also heterozygous for this. The elder sibling did not have any hemophagocytosis. For the other babies, 6 out of the 8 criteria for HLH was satisfied. All 3 of the babies expired. Coming to the discussion part, familial HLH 70 to 80% present before the first year, and about 90% are asymptomatic in the newborn period. Mainly, the most common mutation is PR1 mutation. It is common in specific geographic population and consanguineous marriages. Genetic evaluation is a cornerstone in the diagnosis of familial cases, and allogeneic stem cell transplantation is the definitive curative therapy. Secondary causes like infections have a good prognosis, and literature shows atypical presentations like non-immune hydrops and cholestasis on day 1 presenting as HLH. So finally, to conclude, critical to the diagnosis of HLH is the awareness about the disease and high degree of suspicion in children with some of the clinical features, and prolonged fever with hepatosplenomegaly and pancytopenia need a high index of suspicion of HLH, even if it is associated with sepsis. Thank you.
Thank you, Dr. Anupama. That is an excellent presentation, and it's a very important entity which often goes unnoticed, actually. So my question to you is, do you, in your first case, was there any infectious etiology which was looked for, like rare infection, and was it ruled out?
Rare infections, by we did a TOT screening, it was not there, and also the nasopharyngeal swab for the viral panel, everything was done, but we didn't find any infectious etiology. But since even after 10 days of admission, baby was not that sick, but his fever and this bicytopenia was persisting. Along with that, firm hepatosplenomegaly. Therefore, we thought of HLH and found these findings. But then also we thought it can be a secondary one due to infection. But after consulting with this pediatric oncologist, they told that it can be primary or secondary due to infection, but we could not evaluate the baby further. Genetic study could not be done because the baby expired before that.
So the only thing is in tropical countries, things like dengue, scrub typhus can all mimic like HLH. So those are the other things which we would look for. Thank you, Dr. Anupama.
Thank you, ma'am.
Thank you, Dr. Anupama. I would just like to ask one thing, that what were the other treatment options did you consider in the second case apart from dexamethasone?
The treatment etoposide with the dexamethasone and cyclosporin is the chemotherapy regimen for HLH. And the final curative therapy is anyway allogenic stem cell transplantation. For the second baby, for the first second baby, we could give only dexamethasone. We were planning for that, but the baby was so sick and expired.
Okay, thank you.
Thank you, ma'am.
So we move on to the next candidate. Dr. Fatima, are you ready?
Yes, madam.
So start your screen sharing. Any issue, Fatima? Please unmute. Is there any issue?
No, 1 minute. Hello.
Start presenting. Okay.
Good evening, madam. I am Dr. Fatima Tasnim, neonatal fellowship trainee in Ernakulam Medical Center, Boston. I am here to present a case report on duodenal web. First, about the congenital duodenal obstruction is one of the most common gastrointestinal anomalies in newborns. The incidence of congenital duodenal obstruction is 1 in 2,500 to 10,000 live births, and the duodenal web is a congenital obstruction where a diaphragm or intraluminal diverticulum causes complete or incomplete obstruction of the duodenum. The incidence of the duodenal web is 1 in 10,000 to 1 in 40,000. And when the obstruction is incomplete, in case of duodenal web, the clinical symptoms are variable and the diagnosis can be difficult. And the median age of presentation is usually 8 days. Here I am presenting a case of a 9-day-old outbound term infant with a birth weight of 2.8 kg presented to us with repeated episodes of non-bilious vomiting. And baby passed meconium within 24 hours of life, and vomiting started on day 3 of life and its severity increased. On admission, the baby was mildly dehydrated with a weight of 2.5 kg, there is 10.7% weight loss, and there was no evidence of sepsis. And abdominal examination was unremarkable. And the abdominal X-ray erect was done to rule out interstitial obstruction showed normal gas pattern, and the ultrasound abdomen done to rule out CHPS was normal. And the feeding initiated with anti-GR measures, but baby had persistent vomiting whenever the feeding was attempted. And hence the barium meal contrast study was done, and it showed a constriction at the level of duodenum at D1, and the laparotomy confirmed the duodenal web at D1 D2 junction with an abnormal vessel crossing the duodenum anteriorly. Duodenostomy was performed on day 14 of life, and feeds were restarted slowly through the transanastomotic jejunal feeding tube, and subsequently oral feedings was reinitiated without any vomiting. And baby was discharged on day 20 with weight of 2.9 kg. And the failure of recanalization of the duodenal lumen leads to duodenal web, and the diagnosis of duodenal web is often delayed because of the incomplete character of the obstruction and results in tolerance to limited feeding. And the plain X-ray and ultrasonography are often unremarkable in this case, and the barium meal contrast helps in diagnosis. A typical finding in the barium meal is Winslow sign, that is the peristalsis of the proximal part of the gut, resulting in a prolapse of the membrane in the distal part of the lumen. In our case also, diagnosis got delayed till 13 days of life, and the barium meal contrast study aided in diagnosis. This usually happens with duodenal web due to partial obstruction. The infant will show the feed intolerance only when a particular feed volume is reached, and this can be mistaken as GER and can delay the diagnosis. So I conclude that any baby with persistent vomiting and poor weight gain, even with normal abdominal X-ray and ultrasound abdomen, duodenal web has to be kept in mind, and the contrast barium meal study at the earliest can help in diagnosis. And the early intervention gives the better outcome. Thank you.
Thank you, Dr. Fatima. And you have very nicely summarized atypical presentation of a common condition. So my question to you is, what do you think are the prerequisites before performing an oral contrast? And is barium still used as contrast in neonates?
Gastrografin we can use, madam. But in our unit, we are using the barium contrast.
So what are the problems with barium and what precautions would you take? So barium is very hydrophilic. It will draw water from your intravascular compartment. So you should ensure that your baby is well hydrated. That's all.
Okay.
So thank you. Thank you, Dr. Fatima.
Thank you. Thank you, Dr. Fatima. Actually, the question has already been taken care of by Dr. Bharti. And that was my question also, that what are the complications associated with barium meal? And if given a choice between barium and gastrografin, which one would you choose? I think already the answer is clear now. So otherwise, well presented, Fatima. Okay, thank you, madam.
Okay, we will move on to the next candidate, Dr. Naushid.
Madam, can I share?
Can you share the screen?
Share button is not working. Share sound.
Shruti, we can move to the next one. Now, Shit, can
share,
you
share. Okay, okay.
mail
Share.
your PPT?
It's ready. No,
Okay.
no, it is ready. It is ready. 1 minute. Can you see?
Please, like you are sharing your white screen.
Okay.
You press your share screen,
Okay.
and it will pop up.
Now it is okay, na?
Start share screen.
Now it is okay.
No, you haven't shared. Do minimize this.
Now?
Zoom. No.
No. 1 minute.
For a second, do minimize Zoom. Go
No?
back and let me tell you again. Minimize your Zoom. Open your PowerPoint or PDF presentation again.
Okay. 1 minute. Okay.
Have you done that? You come back to Zoom again.
Okay.
Have you? Now press share screen. And you have to select the screen. Then share.
No, it's not.
Next point.
Okay.
Okay.
Now
So,
it's getting.
No, it's not there. Now started
No.
sharing. Okay.
Yeah.
Okay. It's okay.
Okay.
Make it slideshow. Now it's okay. Start presenting.
Okay. May I audible? Okay. Respected all, I'm Dr. Naushid, consultant neonatals in Jimcare Hospital. My case report is based on a rare procedure, a non-surgical intervention which was used for a large mucus plug obstruction at rectosigmoid level in an extreme preterm baby. A 28-week, 950-gram extreme preterm was delivered by emergency LSCS due to fetal distress and severe oligohydramnios. Baby cried at birth, surfactant was administered, and early CPAP was applied. Minimal enteral nutrition was started on day 2. But baby developed abdominal distension on reaching near full feed and showed poor activity by day 10. Necrotizing enterocolitis and feed intolerance was suspected first, and baby kept in NPO. IV antibiotic was started, and sepsis workup with plain X-ray abdomen was done. After 48 hours, feed was restarted as the baby improved clinically and radiologically, but again developed abdomen distension on reaching certain feed volume of approximately 10 ml. The repeat plain X-ray abdomen revealed significant dilated bowel lobes, and we did plain CT abdomen in suspicion of intestinal obstruction, showed narrowing at the level of rectosigmoid colon. Apart from surgical procedure, we thought to do sigmoidoscopy using flexible bronchoscope, which revealed thick mucus plug obstruction at the level of rectosigmoid junction, and the large mucus plug was removed by the scope itself. Flatus tube retained and removed after 3 days. Baby was better and tolerated full feeds, and weight gain was noted. Since then, the baby was discharged with weight 1.8 on 58 days of life. In the discussion part, we know that neonatal intestinal obstruction is the most common surgical emergency in which may occur any point in the gastrointestinal tract. Intestinal wash and open surgery are the common intervention as considerable morbidity. And here in our setting, sigmoidoscopy and the mucus plug removal was done using flexible bronchoscope, which is a novel conservative method. We were successful in our case in revealing the obstruction, and however, this mode of treatment needs further research. We may keep in our minds about the option of endoscopic intervention before opting for a surgery. The patient was mainly financial concerns was there, and around 950 grams. That's why we adopted this method as a novel conservative method. We used bronchoscope around 6 mm and working port around 2.8, and we didn't use air for dilatation. We use only water, and it take around 3 hours procedure. Thank you.
Thank you, Dr. Naushid, for that excellent presentation of a very innovative technique. So my only question to you is, do you do glycerin syringing
Yeah.
as practice?
We did that one for enema, but the lesion is around rectosigmoid level. That means around 20 centimeter above the anus. That's why that is not worked properly. That's why we first we thought that about the pediatric surgery. Means we asked asked about the surgery thing, but pediatric surgeon also told that 950 grams very poor prognosis. That time we thought about like this. Our gastro surgeon, he helped for doing this. He also did first time this one, and very rare procedure he also told, because it's a very skin 950 gram baby, and babies now is okay. 7-month-old baby is okay.
Yeah, that was innovative. Thank you. That's it from me.
Thank you, madam.
Thank you, Dr. Naushid, for that innovative method. And just one question, like what did you attribute this mucus plug obstruction to? What did you think was actually the underlying etiology for this?
Etiology, madam, actually mucus, normally all the intestinal obstruction will come in the first 48 hours, but this I don't think the why it's formed mucus plug. Most probably the delayed absorption, delayed passage of meconium was there around 48, after 48 hours only passed, and maybe due to some stenosis maybe will be there. I don't know, suddenly after 10 days only this presented the obstruction. That's a mechanical obstruction only, and just above the level of that sigmoid junction. That's why we did this procedure.
Okay, thank you.
Thank you, ma'am.
Okay, now I'm inviting Dr. Shilpa for the next presentation. So, okay, Shilpa, start presenting.
Good evening all. Myself, Dr. Shilpa Arshegar, pediatric DNB resident at Anantapuri Hospital, would like to present the poster on laryngeal web and subglottic stenosis in a neonate with DiGeorge syndrome. So DiGeorge syndrome, also called as velocardiofacial syndrome, Spritzen syndrome, is an autosomal dominant condition with an incidence of 1 in 4,000 births, which occurs due to a deletion in chromosome 22q11.2, which leads to a loss of function of TBX1 gene. And the main diagnostic modality in DiGeorge syndrome is fluorescence in situ hybridization analysis, and the defects associated with DiGeorge syndrome has been acronymed as CATCH22, which stands for cardiac abnormalities, abnormal phases, thymic hypoplasia, cleft palate, and hypocalcemia. So here I present the case of a 9-day-old term female baby weighing 2.5 kg, born to a mother with gestational diabetes mellitus, who was referred to us with aphonic cry and respiratory distress characterized by chest retractions and stridor. The baby had a dysmorphic facies, which was characterized by an elongated face, small palpebral fissures in upstanding eyes, low set ears, prominent cheek, and retromicronathia. On doing video laryngoscopy, we could find a glottic web across the anterior 2/3 of the vocal cord with a small posterior opening, and examination under anesthesia revealed a thick glottic web with subglottic stenosis and critical airway. Hence, emergency tracheostomy was done and baby was stabilized. On doing investigations, we found that the baby had hypocalcemia and hypoparathyroidism with normal levels of phosphorus, magnesium, and vitamin D. FISH analysis came positive for 22q11.2 deletion. Echocardiographic evaluation was normal except for a small patent foraminowave. Chest X-ray showed a thymic shadow, and her CD4 and IgG levels were normal. So studies have shown that DiGeorge syndrome is associated with structural airway abnormalities like tracheomalacia, subglottic stenosis, laryngomalacia, glottic web, and bronchomalacia. However, the frequency of 22q11.2 deletions in children first presenting with glottic web has been reported to be as high as 65%. And anterior laryngeal webs most commonly manifest as respiratory distress or vocal problems. So the main modality of diagnosis and management is to do a flexible laryngoscopy, and the gold standard of treatment is tracheostomy to bypass the problem. And once the child is older, that is 4 to 5 years of age, definitive management like endoscopic excision can be done. So I conclude to state that it is important to evaluate children with laryngeal abnormalities, especially if associated with abnormal phases or cardiac anomalies, to look for 22q11.2 deletion and vice versa. Thank you.
So thank you, doctor, for presenting very crisply and nicely an atypical manifestation again of a common syndrome. So my question to you is, did you have a clinical suspicion of DiGeorge itself? And what is the difference between a fish and a karyotype? Why did you choose a fish over a karyotype?
Since this is a micro deletion syndrome, it would be better to do a fluorescence in situ hybridization so that we can detect the signal intensities by fluorescent by using the corresponding probe like LSI probe, HIRA, tuple, etc., which can diagnose the DiGeorge critical region in fish analysis. On the other hand, karyotyping is more helpful if we are to find out any abnormalities in the number of chromosomes and all.
You're right. Yeah, only if you have a clinical diagnosis, you could do a fish. Okay, thank you.
Thank you, Dr. Shilpa. That was an excellent presentation. Just one question: that how did you prepare this family for discharge to take care of the tracheostomy at home? What all advice did you give? And are they coming for follow-up? How is the baby doing on follow-up?
Yes, ma'am. They are on regular follow-up. We have already taught the parents regarding the tracheostomy care of doing a routine suctioning, and also to report immediately if they find any sort of breathing difficulties or abnormal discharges from the tracheostomy side. And at every visit, we are regularly following up the growth and development of the baby, as well as we are also, the baby is currently on calcium and multivitamin supplementation. So at every visit, we are doing the calcium and phosphorus levels to ensure that it is in the normal range, and to adjust the doses if any abnormality is detected. And also, since her CD4 levels and IgG levels were normal, and the chest X-ray showed a thymic shadow, we had also given immunizations for the baby, and she was tolerating them.
Okay, thank you.
Thank you.
Okay, we move on to Dr. Sriram for the next presentation.
Yes, ma'am. Ma'am, can you see the slides, ma'am?
Yes, but it's not full. Can you reduce the size? Scroll. Or you have to scroll it down during your presentation.
Yes, ma'am. I'll scroll it like this. So I can do it like this.
Okay, start.
Okay. Good evening, everyone. Myself, Dr. Sriram. I'm a DM resident from MYC Medical College, Korancheri. It's a case report of complicated Hirschsprung's disease. Sorry, introduction. Hirschsprung's disease is also known as congenital megacolon or aganglionus coli, with incidence of 1 in 5,000 live births with male preponderance. The main pathogenesis, there is a defect in the craniocaudal migration of neural crustals derivatives. Treatment of choice is surgery. It's a case report. It's outborn baby, term 38 weeks, 3.2 kg male baby, infant diabetic mother, born by normal vaginal delivery to 36 years old G3PT-L2 mother. Infant cried soon after birth and shifted to the mother's side. Baby was on diet breastfeeds. And baby passed with meconium within 24 hours of life. And baby got discharged on day 4 of life. And baby got readmitted on day 8 of life for neonatal hyperbilirubinemia. And baby found to have poor acuity with abdominal distension. And baby was referred to our center on day 9 of life. On examination, baby was sick. Baby was in shock and having tachycardia with the poor perfusion. On examination, per abdomen examination, abdomen looks to be distended, tender on palpation. On auscultation, bowel sounds are absent. Other systems, no abnormality detected. Course and management in the hospital. Baby was initiated on SIV support, with IV fluids, inotropic support, and antibiotics are started. X-ray abdomen shows peritoneum. gas in the diaphragm, and taken up for laparotomy. Their ascending colon was gangrenous and 2 perforations were seen in the ascending colon, also cecum with fecal peritonitis, and bowel segments were resected due to devitalized tissues, and right hemicolectomy done with iliotransverse anastomosis, and biopsy taken from the sigmoid colon muscle biopsy showing absence of ganglion cells. The muscle layer showing absence of ganglion cells. And coming to the investigations, total counts were reduced. It was 1,000, and sodium was 133. Remaining electrolytes were normal. And coming to the post-operative course, baby was on SIMV support, and sensitive antibiotics were started for Klebsiella pneumoniae sepsis and E. coli peritonitis. By day 5 of life, baby was exposed to CPAP. 2 feeds were started on day 12 of life. Baby had adherent burst abdomen with intracutaneous fistula. It was noted on day 13 of life and was treated conservatively, and baby got discharged on day 22 of life. Coming to the discussion, some of the causes of intestinal perforation in the newborns are spontaneous intestinal perforation and some perforation secondary to NEC, and Hirschsprung's disease, intestinal ectasia, all mechanical obstruction causing dilated bowel segments and perforation, meconium and plug syndromes, and some congenital defects in the musculature, and diverticular and intestinal neural dysplasia. This is very one of the rare condition which can be of 2 types, type A and type B. Type B is usually clinically resembles Hirschsprung's disease. In our case, the sigmoid colon muscle biopsy shows absence of ganglion cells. It's a typical feature of Hirschsprung disease. It's a term baby, male baby with agangliosis presented with signs of peritonitis and colonic perforation. Diagnosis complicated Hirschsprung disease. Coming to the conclusion, for any neonate presenting with apparently unknown cause of colonic perforation, despite history of passing stools within first 24 hours, Hirschsprung disease cannot be ruled out, and an effort should be taken to determine the histopathological diagnosis.
Yeah, thank you, Dr. for that nice presentation on Hirschsprungs. So now you said that baby did pass meconium on 24 hours of life. Do you
Yes,
know
ma'am.
what was the stooling pattern after that? That was my question. My second
Yes,
question,
ma'am.
if this parent were to have another child and they ask what is the chance that my second child would also have a Hirschsprung, how would you answer?
Yes, ma'am. This baby initially, baby has passed stools within 24 hours of life, and after surgery, after first 9 days of life, also baby is passing stools. Its stool pattern is 3 to 4 times per day. Baby is passing stools, and by day 8 or 9, yellow color stools baby is passing. Post-operatively after surgery, day 3 post-operative day, baby is passing stools, yellow color stools. And regarding the if they want to plan for the second child, my question is, Hirschsprung disease it may be sporadic, or it may be genetic predisposition may be there. Genetic predisposition is where most commonly it's sporadic. Some genes will be there, like red protonco gene mutations. All these things will be there, like SOX10 gene mutations and LICAM gene mutations will be there, and we have to rule out all. And endothelium gene receptor 2B mutants will be there. So some chances will be there, but most commonly it is sporadic.
You're right. Thank you, Dr. Sriram. Now over to Dr. Swati.
Thank you, ma'am.
Thank you, Dr. Sriram. So,
Thank you.
what are the late complications you're expecting in this baby, and how did you prognosticate the family regarding this baby?
Yes, ma'am. Regarding the late complications, baby had in surgery. It's an extensive operative surgery. Some anastomotic leaks will be there, or stitches will be there, and sometimes there will be fecal incontinence will also be there. And sometimes there may be some chance of because of perforations, there may be again because of the anastomotic leak, again sepsis chances might be there. So regular monitoring and regular follow-up is very important. And regarding the prognostication, as it involves only ascending colon, most of the ascending colon only water absorption electrolytes takes place, and we have resected only 2 to 3 centimeters of ileum, that is terminal ileum. So majority of the terminal ileum is preserved, where vitamin B12 and bile salts are there, and small bowel is also perfectly normal. So long-term prognostication will be it will be okay, it will be better. So we have to tell them to follow up.
Okay. Thank you, Dr. Sriram.
Thank you, ma'am.
So next is angios. Madam, can you take the previous slide? Okay. Now it's okay, madam. You can start presenting.
Can I start?
Yes, ma'am.
Good evening to everyone. I am presenting a pilot study on chronic lung disease of prematurity in neonates, also known as BPD, managed with nasal high-frequency oscillatory ventilation. Non-invasive ventilation modes provide respiratory support without endotracheal tube. These modes are used to minimize ventilator-induced lung injury. Nasal HFOV is one of the promising modes in this regard. The study was designed to compare the incidence of CLD in nasal HFOV and NIPPV when used as post-extubation respiratory support. This is a prospective observational pilot study conducted during the period from January 2020 to August 2020, including neonates less than 34 weeks of gestational age with no major congenital malformations. Post-ventilator support, these infants were allocated on an alternative basis. Primary outcome was incidence of CLD, and the data was analyzed using SPSS20. Demographic characteristics and outcomes were compared using Pearson's chi-square test. Total number of neonates in our pilot study were 20, and among them 10 in nasal HFOV and 10 in NIPPV. Number of neonates less than 28 weeks were comparatively more in nasal HFOV. Regarding the primary outcome, in less than 28 weeks, 30% in nasal HFOV had CLD versus 10% in NIPPV with p-value of 0.017. In neonates between 28 to 34 weeks, CLD was 20% in nasal HFOV and 10% in NIPPV. In the other outcomes, there were no difference in NEC, IVH, duration of hospital stay, mortality, and extubation failure. The duration of respiratory support required was almost similar with no incidence of air leak. There is very little literature on this subject. The incidence of CLD was more in our study in nasal HFOV. However, the other 5 published studies, Aktas S. et al., Amit Mukherjee et al., Fisher H.S. et al., R. Iranpur et al. Found that nasal HFOV is beneficial for preterm infants in prevention of CLD. The major limitation of our study was it is being a pilot study, sample size was very small, and since this was a chance allocation, there were more babies in nasal HFOV group. Majority of the babies less than 28 weeks were nasal HFOV. This could have affected primary outcome in our study. Study was conducted in early days when we started in nasal HFOV as compared to NIPPV, which we were using in our unit for many years. It is a known fact that there is a learning curve when a new intervention is initiated in NICU. Non-blinding was also another limitation. To conclude, nasal HFOV is a feasible method of respiratory support in preterm neonates. Outcomes studied were similar in both the groups except CLD, in which the incidence was found less in NIPPV, probably due to lower gestational age in nasal HFOV group and small sample size. A well-designed, multicentric, large randomized control trial is required to validate outcome. Thank you all.
Thank you, Sister Antos. That's a very interesting study and it was nicely presented. My question to you is, what were the problems do you think that led to higher CLD in those babies less than 28 weeks who got nasal HFOV? What do you think were the problems?
In nasal HFOV, the extreme preterms were very, the number of extreme preterms were more in the nasal HFOV group. And that babies are more prone to get CLD.
So the other thing is, if you were to design an RCT, what other precautions, what lessons have you learned from this pilot study that you want to incorporate?
The allocation should be equal in both the groups, and the babies should be divided in both the groups equally. Both the extreme preterms and less than 28 weeks and 28 to 34 weeks should be equally allocated in both the groups.
Okay. Thank you. Over to Dr. Swati.
Thank you, Sister Jose. That was a wonderful presentation. I have just 2 questions. That if you were to design this study again, what is the population of neonates you would like to choose for studying this outcome? And whether CLD is the primary outcome you would like to study or something else?
Ma'am, other than CLD, the secondary outcomes, extubation failure is another choice of study, ma'am.
Okay, thank you. I think we can move to the next one.
Okay, we move on to Dr. Krishna. Krishna?
Hello, is my screen visible? Hello.
Yes, Krishna, you can start.
It's not coming. Sorry, ma'am, my screen is not coming, ma'am. Just a minute.
Visible. It's actually visible.
Oh, okay. Okay, so I'm presenting a case series on acute limb ischemia in neonates admitted in our NICU in last 1 year, and I'll be dealing with the clinical manifestation, the management, and outcome. So my first case is a term female baby who was referred to us with a ulcer at the right cubital fossa on day 1 of life, and this mother was having irregular checkup due to our pandemic. And on examination, the baby had another ulcer at the right wrist, discoloration of that limb, and a constriction band. The ultrasound Doppler done showed that there was right axillary artery thrombosis and absent flow to the arteries below, but there was significant collaterals. So this baby also had thrombocytopenia. So we gave platelet transfusion, start the baby on low molecular weight heparin, and gave for 2 weeks. And the Doppler became completely normal by 2 weeks. And we switched to warfarin. And even though we try to continue the therapy, because of the elevated VTNR, we had to stop at 1 month. And we monitored the baby. She was doing fine. And the limb was normal at discharge. Now she is 8 months old without any complication with good function of that limb. And the second case is an extreme preterm female baby born to a primary mother with PPROM history of 10 days. And this baby also had edema and discoloration of right upper limb right from the birth, and a constriction band at the wrist with feeble pulses. The Doppler showed decreased monophasic flow in the proximal radial and ulnar artery. And this baby was started on nitroglycerin patch from the moment of admission itself, and this baby showed improvement. So we continued with the same and gave for 10 days. Edema decreased dramatically and the color improved, and the Doppler was normal at 4 days. But this baby had a normal limb at 14 days of life, but because of some unrelated cause, this baby unfortunately expired on day 27. My third case is of a term baby, 2.33 kg, with referred to us on day 10 with failure to thrive, and on admission there was 37% weight loss and lethargy. And this baby, after 3 hours of admission, started having discoloration of her right foot, and it started spreading rapidly. So an urgent Doppler done showed that there was no significant flow in the superficial femoral artery. Her admission sodium was 193. There was associated thrombocytopenia and altered coagulation profile. This baby was started with FFP and platelet transfusion, started on low molecular weight heparin. Sodium correction was also started, and the baby required iron drops also. And the discoloration slowly improved. And by 3 weeks, that discoloration localized to the tip of her toes, and it got auto amputated at 5 weeks. She is also on the follow up, and baby is doing fine, and even the sensorium is good. In case 4, it is an extreme preterm baby who was born to a diabetic mother with a PPROM history of 3 days and born at 25 weeks of gestation. And this baby had left upper limb ischemia with tip of the fingers being involved, and the Doppler was showing absent flow in radial and ulnar artery. This baby had severe DIC at birth, and despite our best effort, this baby expired at 6 hours of life. My last case is of a preterm baby born to a mother with diabetes mellitus, and she was born at 27 weeks. And this baby had started developing discoloration of the left big toe of day 3 of life, and there was a significant demarcation line. The Doppler showed decreased flow to the dorsalis pedis artery, and the sepsis markers were positive, and there was thrombocytopenia. So this baby was started on low molecular weight heparin, nitroglycerin patch, and also antibiotics. So this baby improved. Now she's 1.5 months old, and he's doing fine. So the case series, I would like to put my results as the antenatal risk factors include extreme prematurity, mother having diabetes, and PPROM. And the etiologies we could find were constriction bands, dehydration, and sepsis. The most common associated finding was thrombocytopenia, which was there in almost 4 cases. And duration of therapy we have given is 2 to maximum 4 weeks. The outcome, I would say, it is good because 4 out of our 5 babies improved, and 2 extreme preterms expired. One baby was very sick, and the other baby died due to unrelated cause. And what I would like to conclude is, when you have, you should anticipate acute limb ischemia, and especially in extreme preterm babies, and when they have sepsis, dehydration, and especially in the infant of diabetic mother, we should start low molecular weight heparin early. It is safe, and even the book says 3 to 9 months. Even a 2 to 3 weeks of short duration therapy may be enough. And thrombophilia workup is costly for a government setup, so if you have a proper course, it might not be needed. That's all. Thank you.
Thank you, Dr. Krishna. That was a wonderful presentation, and I congratulate your team for such wonderful management. My question to you is, what is purpura fulminans, and how did any of your baby fit into the definition of that, and how the management of purpura fulminans is different from what you have done?
Madam, purpura fulminans usually present when a baby is started on warfarin therapy, ma'am, especially if the baby have any thrombophilia or a significant thrombophilia. And such baby presents with a rapid crash and shock, and the baby will be very sick. So such babies, so that we should, that's why we had monitored that baby before we started warfarin also. But it didn't happen, ma'am. None of them developed the same.
The only thing is, in purpura fulminans, the most common cause, I mean, non-infectious cause is protein C. So there we would get protein C in the form of SSP.
Concentrate. Yes, ma'am.
So thank you, and over to Dr. Swati.
Thank you, Dr. Krishna, for a wonderful presentation.
Thank you.
I would just like to ask that none of these babies had any central lines, right?
No, ma'am, none of them, ma'am. I couldn't add because already my slide was full. None of them had any arterial cannulation, ma'am.
Yeah, so that is important to mention. And secondly, was there was any monitoring for low molecular weight heparin done?
Madam, ours is a government setup, ma'am. So ideally, we should monitor anti-factor 10A, but that was not possible, ma'am. So once warfarin was started, only clinical monitoring was done, ma'am.
Okay, thank you so much.
Thank you, ma'am. Thank you so much.
So we move on to next candidate, Dr. Anu Sharma. Anu, we will share your presentation from here.
Okay, ma'am.
Sorry, we will move on to the next candidate and then we will come back, Anu. So we, Dr. Anupama Tanga, are you ready?
Ma'am, I'm ready.
So you can start slide sharing.
Good evening, everybody. I am Dr. Anupama Tanga, DNB resident of Anandaburi Hospital. I am here to present a poster of brachytelephalangic type chondrodysplasia punctata and underdiagnosed NDT. It is a rare X-linked recessive type of congenital disorder affecting cartilage and bone development. It is characterized by binder phenotype, that is depressed nasal bridge, crescent neris, hypertelorism, acute nasolabial angle, short columel, and a convex upper lip. Then a stippled epiphysis and short distal phalanges in male child. It occurs due to loss of ARC gene activity. Genetic confirmation can be done by either finding a deletion or mutation in this ARC gene. So the importance is, according to latest literature, there is no genetically confirmed cases from India so far. So case report, a newborn baby with respiratory distress and nasal dysplasia got admitted in our hospital, and detailed examination revealed binder phenotype and brachytelephalanges, short stout extremities. Skeletal survey showed stippling at epiphysis of posterior arches of vertebrae, humeral and femoral head and acetabulum. Lateral skull X-ray showed absent nasal bone and septum, and X-ray hand was suggestive of a triangle-shaped terminal phalangeal stippling and shortening. genetic workup done, and NGS confirmed an X-linked recessive pattern of mutation in ARSA gene. At 6 month developmental delay with increased spasticity and torticollis of left side nodded, and MRI brain normal, and physiotherapy and developmental therapy started. Discussion part, it's a rare X-linked recessive form, even though its prevalence is 1 in 5 lakh. All literature showed only 55 genetically confirmed cases all over the world. It's a vitamin K dependent enzyme gene mutation affecting calcium deposition of bones, characterized by facial dysmorphism, brachytelyphalange, and epiphyseal crippling. ARSA gene is the only way to confirm the diagnosis, and the complication can be a cervical spinal instability and airway stenosis. Usually, this condition is associated with good prognosis, and this calcification usually disappears in childhood. But some studies noted a developmental delay, cardiac abnormalities, cataract, sensory neural hearing loss, and coloboma. So we should know that this binder phenotype is associated with chondrodysplasia punctate sometimes. So hypoplastic midface, an important prenatal clue for diagnosis. And if we suspect that condition, a prenatal 3D ultrasonography of spine will detect vertebral stiffening. So all suspicious binder phenotype in antenatal scan should be valid for CDP. Coming to the conclusion, binder phenotype is often treated as an isolated one, and brachytelyphalangic type chondrodysplasia punctate is underdiagnosed in most of the times. So the prenatal diagnosis will help to anticipate respiratory distress soon after delivery in most of the cases, and regular follow-up is required for good prognosis. So the key message behind my poster is prenatal and postnatal binder phenotype should be evaluated for chondrodysplasia punctata, and early diagnosis will result in better management and prognosis. And the relevant figures I noted here with showing binder phenotype and stippling and all. Thank you.
Thank you, Dr. Anupama, for that wonderful presentation of a very rare case. My question to you is, when this baby was born and when you did not have the genetic thing, what was your clinical diagnosis? And my second question is, what do you mean by variant of uncertain significance, which you have put up on your genetic test?
Since it's a very rare entity, usually we won't think about if a child like this come. So first we will think about normal condition like Down syndrome showing this nasal hypoplasia and all, then trisomy 18, some warfare in embryopathy. These are conditions can also show this binder phenotype and all. First we will think about that, but there was no history of any warfarin use in mother and all. And so we also noted this brachytelyphalangic type, that short stout extremities. Then only we think about this rare entity, brachytelyphalangic type chondrodysplasia punctate.
My second question was, what do you mean by variant of uncertain significance?
Since actually I directly asked this Medgenome people because they had written like that. They said that because of this rarity, they actually don't know the significance of this condition. So that's why it's, according to them, there is only 10 raised to -3 frequency of this allele for getting positive in this population when they totally examined in this genome sequencing.
Thank you.
Thank you, ma'am.
Thank you. Dr. Swati has no questions for this session, for this presentation. So we are moving on to the next candidate, Dr. Anu Sharma. We'll start screen sharing from here.
Oh, thank you, ma'am.
Okay. Okay. Okay, Anu, you can start presenting.
Okay, ma'am. Good afternoon, one and all. I will be presenting a case series on hypotonic neonates with feeding difficulty. As we all know, hypotonia with feeding difficulty is a common cause for referral to tertiary care center, and if not addressed timely, can have great impact on patients' morbidity and mortality. So to study the etiologies associated with such presentation in immediate newborn period, we present a case series of 4 hypotonic neonates who were referred to us in the year 2020. We had 3 term babies and 1 was late preterm. 2 of them were male and rest 2 were female. Antenatal history of decreased fetal movement was there in 2 patients, and there was history of 3rd degree consanguinity in 1 of our patients. Patient 1 was referred on postnatal day 7 for having apnea while feeding and was found to having hypotonic upper limb with lower limb contractures. Laboratory investigations, neuroimaging and flexible laryngoscopy were normal in this patient, and on further evaluation, next genome sequencing revealed mutation in rhinodin 1 receptor causative for central core disease and autosomal recessive inheritance in our baby. Second baby required intubation at birth and was having hypotonia, labile cardiovascular functions, drooling, bilateral CTB. Investigations including imaging were normal in this patient too, and next genome sequencing revealed mutation in dystotin gene causing hereditary sensory and autonomic neuropathy type 6. Third patient was referred on postnatal day 13 for having excessive drooling and persistent respiratory support requirement from birth. Baby was found to be encephalopathic and had seizures too. For that, baseline investigations, IEM workup and neuroimaging to rule out hypoxia was done, and it was found to be normal. On next genome sequencing, we found that patient had mutation in collagen 6A1, pathogenic for Bethlem congenital muscular dystrophy, but it was considered as variants of unknown significance in our baby, as mother was also found to having same mutation and she was asymptomatic. Fourth patient was referred on day 1 for having respiratory distress, hypotonia, poor suck reflex and swallowing difficulty. Laboratory investigations including CPK, SMN gene study, MRI brain and next genome sequencing all were inconclusive in this patient, and on further evaluation with electromyography we found a decremental response and double compound action muscle potential on repetitive nerve stimulation, diagnostic of slow channel congenital myasthenic syndrome, and patient was started on fluoxetine and salbutamol. On discharge, baby had good swallowing function. Baby was directly feeding from breast, but some delay in motor functions is persisting. So we could find that main etiologies associated with hypotonia and feeding difficulty in the immediate newborn period in our patients were of neuromuscular disorders. To conclude, feeding and swallowing dysfunction with hypotonia carries a poor prognosis. Next genome sequencing is important to reach out to a diagnosis so that a prenatal evaluation and genetic counseling to the parents can be offered during next pregnancy. And electromyography has a diagnostic role in peripheral lesions like congenital myasthenic syndrome, helping in immediate management with relatively good prognosis. Thank you.
Thank you, Dr. Anu. That was a fantastic presentation. And again, I congratulate that team for making such wonderful diagnosis. My question to you is, in all these 4 babies, in how many of them were you able to arrive at a diagnosis clinically? And my second question is, how do you differentiate myopathy, neuropathy, and what is dystrophy?
Ma'am, in all of these patients, as all of them were having hypotonia, that were characteristics of peripheral causes like neuromuscular. So we were till we could reach at the point that it may be a peripheral cause or neuromuscular cause for hypotonia. But what it could be definite, for that, done next genome sequencing.
So how do you differentiate a neuropathy, myopathy, and what do you mean by dystrophy?
Dystrophy, there will be patients, mostly these kind of patients will be born with contractures. There will be history of IUGR babies, and with the clinical evaluation itself, we can have an idea of if this baby is having dystrophy. But in myopathy and neuropathy, myopathy basically mostly there will be baby will be having hypotonia with the poor power, areflexia, and it is very difficult to differentiate clinically in babies with the from myopathy and neuropathy, because sensation and all, it is especially the babies who are intubated and who are already in altered sensorium, it is difficult to differentiate clinically.
Yes, but the only things what you could observe from these babies are where is the pattern of wasting, whether the wasting is distal or whether
it was or proximal.
So when you have
we had a proximal.
Yeah, you would see it is neuropathy. Proximal wasting is myopathy. The second is you would also examine for the deep tendon reflexes. Absence of, again, indicates
that were absent in all of them.
The other thing is tongue fasciculations. Your other thing is SMA. SMA also can present like a floppy neck. So at least these characteristic neurological examination findings will help you clinch a clinical diagnosis sometimes, but most of the time we don't. Thank you, doctor. Now, over to Dr. Swati.
Thank you, Dr. Anu. Actually, I just joined back in the later part of your presentation, but it was a nice presentation. And just I would like to ask you, in the third baby, you had mentioned that the baby was discharged, right? So the baby was discharged on tube feeds?
Yes, ma'am.
So what are the feeding management plans for such babies? Are there any physical interventions or oral motor stimulation exercises which you have advised? How are you planning to manage the feeding of this baby now?
Ma'am, as this baby was having feeding difficulty, we discharged on tube feedings, and parents were described for oral motor stimulation, like we do in preterm infants, oral motor in the form of oral motor stimulation. But what we found that without that only, after starting our medications, fluoxetine and salbutamol, in the next week, baby started having showing cues for started having sucking and all, and was started taking breastfeeding well from.
Okay, thank you.
Okay, we move on to the next candidate, Dr. Ashrin. Dr. Ashrin. Okay, Dr. Ashrin, you can start presenting. Ashrin, is your mic working? Ashrin, can you say good evening? Not working.
She should respond. Actually, you are not audible.
Hello. Can I audible?
Yeah,
Yes,
now you are
yes,
audible.
yes.
Good evening, everyone. I'm Dr. Ashrin, a fellowship training in Ernakulam Medical Center. My positive topic is unusual case of neonatal cyanosis, that is valvular cyst. It's a rare entity which accounts for 10 to 20% of all laryngeal cysts. It's a retention cyst which formed due to ductal obstruction of the mucous gland or minor salivary glands in the varicula and tongue base. It's a rare cause of stridor and respiratory distress in infancy and associated with sudden airway obstruction resulting death. We had a case that 16 hours of life, outborn baby with birth weight of 2.8 kg presented with multiple episodes of cyanosis and occasional inspiratory stridors while crying. Each episode was lasting only 1 to 2 minutes. On examination, baby was system within normal limits, and echo and blood investigation done was normal. And we did a flexible laryngoscopy, which done on day 2, showed thin wall cyst in the valvula, pushing the epiglottis anterior, causing supraglottis obstruction. And for confirmation and to know the extent of the cyst, we did an MRI, showed well-defined thin wall cystic lesion measuring 8.6 to 9.4 mm, noted in the valvula. And on day 3, we did a massivization of the cyst done. And the neonate requires intubation for 1 day postoperatively, and baby was extubated and restarted on feeds. Baby discharged home by day 10. As a discussion part, stridor is the most frequent symptom, and other symptoms are respiratory distress, apnea, cyanosis, and hoarse cry. And failure to thrive is uncommon. Our baby present cyanosis as most frequent symptom, and most of the affected infant developed symptoms within the first week of life. Our baby developed cyanosis and inspiratory stridor at 12 hours of life, and upper airway obstruction was detected during flexible laryngoscopy. The flexible endoscopy is the most helpful diagnostic tool, and MRI is a valuable imaging method to determine the extent and content of the lesions. Endoscopic multiplication is the recombinant surgical approach in infants, and it's a long-term prognosis of valvular cyst is generally good with minimal recurrence rate. And we should consider DDs as valvular cyst for thyroglossus cyst and dermal cyst. For conclude, to raise awareness of valvular cyst to help reduce the therapeutic delays that are currently encountered clinically and to prevent the sudden airway obstruction resulting death. Thank you.
Thank you, Dr. Ashrin, for that wonderful presentation of a very rare case. My question to you is, when the diagnosis was confirmed by laryngoscopy, what additional information did the MRI give you? And secondly, what did you mean by marsupialization of the cyst?
Marsupialization of cyst is the excision, is the aspiration of cyst, and the edges are suturing. That is to prevent the recurrence rate. And MRI also we can shows the cyst size and the extent of the lesion.
Thank you, Dr. Ashrin.
Thank you.
Swati.
Thank you.
Thank you, Dr. Ashrin, for a very wonderful presentation. And I would just like to ask you, what is the take-home message of your case?
You should suspect any case present with intermediate neonatal cyanosis, where baby develop cyanosis while crying and all. You should screen the other systems, and other systems should be rolled out, and we should examine this and 1 second, ma'am. And we took laryngoscope examinations, which is valvular cyst. We should suspect the laryngeal valve, laryngeal malacia as DDs, and if after that we should sorry ma'am, I could.
No problem, no problem. It's okay. I think it's okay. Relax, that's okay. I think we can move to the next presentation.
Okay, so that was the last presentation.
Okay.
So I thank all our vibrant residents from all over Kerala for the efforts they have taken, and also to our sweet and beautiful judges for the patient listening. And I'm inviting Dr. PMC sir for concluding the session.
Hello, hello, good evening. And thank you very much, all the judges, especially Dr. Bharati, Balachandran, our own Dr. Swati, then Anish. Actually, I wanted a gallery view or shot, screenshot of all these people together, but at least 4 of us can take it, isn't it? Then we should thank also all the program coordinators, especially Femida, Anand, Ashwade, just actually conducting this sort of presentations through the webinar is really difficult. So in spite of the COVID-19 pandemic, heavy rains right now in Trivandrum and the vagaries of the internet, we manage. So that is, we should give a clap to all the faculty and the organizers. So the results will be announced and the prizes will be given on 9th May, Sunday, during our inauguration ceremony. So thank you very much. Dr. Manoj, you want to say something?
Yeah, and so anyway, thank you everyone. Thank you all the faculty for sparing your time, judges for sparing your time to evaluate the papers. We had again, like every time, we are having better and better, higher quality presentations. So that's something nice to know. Now regarding,
can you have a photograph? Can you have a photograph?
Yeah, whoever is there, please enable your videos. We'll take a photo. Please give me a minute. Yeah, please enable your videos. Swati, how are you? Long time.
Anand is there, Swati is there.
Yeah. Who is this? I mean, the person is. It's not change the name. Somebody. I don't know. Anyway, shall we go ahead with photo?
Okay.
Yeah. Please give me a minute. Great. Thank you.
Thank you. Thank you.
Thank you.
We have a short time for the.
Yeah, one second, sir. So I would again invite all of you to continue to be with us in the next 2 days, tomorrow and day after, and then all the awards, as PMC sir said, will be presented during the inaugural function on Sunday, Sunday morning. The details will be shared in the group.
Okay. And 6 o'clock we are starting the real.
The CME we will start at 6 o'clock. Please join back.
Okay.
Thank you, everybody.
Thank you. Thank you, everybody. Thank you, Swati.
Thank you, sir. Thank you, sir. Thank you, ma'am.